think good morning, everybody. I'm pleased to welcome you. I wish we were all in person at the St. John's Inn, but we'll take what we can get. We have 95 people in the meeting this morning. This is our biannual meeting starting off 2021. I want to welcome our patients and caregivers for whom everything is designed, directed, and dreamed, members of our practices, our hospice partners who have joined in us in partnering to provide the best care we can, Blue Cross Blue Shield leadership, our partners at Blue Cross Blue Shield, our other guests, and our community partners. So everyone knows our meeting's being recorded, so you'll be able to listen to this later and share it with your practice partners and other colleagues. Please keep your video on if you don't mind. It does help those of us who are talking to know who we're addressing. And feel free to stand up and move about if you want to stop your video for a moment, but when you come back, join again. Our focus today is on palliative care in our patients with cancer. As you know, our purpose and vision for MOQC is cancer care, patients first, the best care everywhere. I'll have the next slide, please. Just so everybody knows how to use Zoom, you'll see here this little screenshot shows you can put things into the chat. We're going to be using the chat a lot today. We want to keep people really engaged and also keep the flow of the meeting. So Dr. Emily Mackler will be monitoring the chat, and you can see the button over on the left side where you can just mouse over mute and unmute yourself. If there's a lot of background noise and you've unmuted yourself, we'll probably mute you again, just so dogs like my Daisy can't come in and interrupt, but we do want to hear voices as well. See you in the chat. I'll have the next slide, please. Just so everybody knows, and I think Louise, you were going to address this slide, so I'll turn it over to you.
Yes, good morning, everyone. Just briefly, before we start, as you know, at most of our meetings, we're able to afford everyone free continuing education credits. So for physicians and for administrators, there are 4 credits for this meeting. We have obtained 3 pharmacist credits for this meeting and 4 continuing education hours for social workers. What is new at this meeting is, as you know, 1 physician from each practice must attend the entire meeting in order to be counted as participation towards the value-based reimbursement that our collaborative provides for Blue Cross Blue Shield value-based reimbursement. Because of the virtual nature of our meetings and until we get back to in-person meetings, we are asking at this meeting for you to complete the CME portion of this meeting and the 4 Blue Cross Blue Shield quality questions in order to represent your participation at this meeting. So we are no longer just taking attendance that you were here. You must complete the CME component and the 4 Blue Cross Blue Shield questions in order to activate your completed participation for this meeting. Now, you do not have to complete your CME immediately after this meeting. Participation to complete your CME is open for 6 months. Now, we would encourage you to do your CME as close to this meeting as possible, but we will take your participation credit anytime up until the CME closes. So at the end of this meeting, and what we will send out to you at the conclusion of the meeting will be instructions. If you have not registered for CMEs previously, or if you have a registered account, reminders as how in terms of how to activate your account again. But just being on this call is not recognized as sufficient to be your participation for the 1 biannual meeting, which you must have in order to meet the participation requirement for the value-based reimbursement. So thank you very much. And I'll turn it back to Jennifer.
Great, I'll have the next slide, please. So we have a Twitter account, and this is our email here. If there's anything that you want to communicate with us about after the meeting or at any time. I'll have the next slide. So our agenda today, this is our welcome. And I am ready now to introduce a special guest. As you know, we like to center everything we do on our patients and caregivers. So actually, before I introduce our patient, I'm going to introduce Dr. Temmel, and then I'll have Heather speak. So Dr. Temmel, as you know, we've been talking about Dr. Temmel for a while, is a medical oncologist and professor of medicine at Harvard Medical School. She's the clinical director of thoracic oncology at Mass General Hospital, co-director of the Cancer Outcomes Research and Education Program at the Massachusetts General Hospital Cancer Center, as well as co-leader of the Dana-Farber Harvard Cancer Center Outcomes Research Program. Something you may not know about Dr. Temmel is that she plays golf, enjoying spending time with her husband and her kids, and actually her son plays golf at Northwestern. Now I'll turn it over to Heather, our special guest.
Thank you so much, Dr. Griggs. I'm grateful for this opportunity to meet with you all this morning. I wanted to tell you about my cross-country runner. I don't know if you guys can see me or not. Hopefully.
We can.
Good. This is Liam, and Liam earned his varsity letter as a freshman in high school in both cross-country and track and field. He was competitive, and I can recall after one race, he'd really pushed himself and he started feeling a little lightheaded. His vision went a little bit blurry. And we were concerned, but by the time we got him home, he was feeling okay. And I still decided to take him in just to make sure everything was okay. And he was referred to a cardiologist. Thought, well, let's just make sure, let's just get his heart checked out, and everything checked out good. So he just determined that he would stay hydrated for the next race. Later in his sophomore year, Liam started experiencing a little bit of a change in his gait when he ran. At first, we thought it was maybe a hip flexor, injury or some kind of an alignment issue. We kind of investigated that option and then went to a podiatrist because his foot was just kind of hitting the ground. His left foot was hitting the ground different than his right foot. So we took him to a podiatrist, and again, everything looked okay. So Liam just pushed through and kept running. A couple weeks later in gym class, he was trying to dribble a basketball with his left hand and realized that his left hand was no longer able to dribble a basketball. And that's when we really knew that this was probably not an alignment issue, but it was leading towards being a neurological issue. So I started calling everyone that I could possibly find in any connection anywhere to any medical facility, trying to get an MRI scheduled for Liam. I was told by a couple of our first picks that it would be a month out before they could get Liam into the MRI. And as a mom concerned about her teenage son, I kept calling, and I found a facility that was able to get him in right away. So he had his MRI, and for the next 24 hours, we just went about our business as normal. And we were sitting in Olga's restaurant. Those from Michigan here know Olga's, and we're sitting together as a family. And my phone rang, and I was sitting directly across from my 16-year-old son at the time. And a neurologist called, whose name I didn't catch. And he started to tell me, he just kind of rattled off all of the scientific jargon. I wasn't comprehending it. He was in a flat tone. He didn't pause or take a breath or ask me if it was an okay time, or even prepare me in any way for what he was about to say. He literally went on for about 5 minutes in this very one-sided kind of conversation. And by the end of the conversation, there was a phrase that I understood. It was the first phrase that I understood from anything that he had told me. And it was, So you'd better follow up with an oncologist. Well, I knew what an oncologist was. And I knew from my son's face, who was looking right at me as I was on the phone, that he knew that his mom was worried. Now I'll fast forward a bit. It's enough for you to know that we did our research as her family. We sought out the best of the best. And within a month of that initial MRI, Liam had a successful brain biopsy at CS Mott Children's Hospital at the University of Michigan. We found out that Liam had an infiltrative, inoperable, cancerous tumor. You guys will love those layman's term. But he spent his 17th birthday recovering from his brain biopsy at Mott Children's Hospital as we kind of digested his new reality. I'm not here to get into the specifics about his exact medical condition or his treatments, but I do want to share that we did receive exceptional care by both the oncology team at Mott as well as the oncology team at Beaumont and the Proton Therapy Center as well as his neurologist, Dr. Alexandra Shaw at Beaumont. And so we did receive some exceptional care. Throughout my son's nearly 3-year battle, we were not blessed to ever hear the words remission or cancer-free. We learned to be quite content and happy with the word stable. Liam's junior and senior year of high school were mixed with chemotherapy, radiation treatments, dealing with seizures, at times being in a wheelchair, at times not being able to utilize most of his left side of his body. But after some success with proton radiation and chemotherapy, Liam's tumor on his right brain was holding stable. And his left hand and his left leg actually regained some of their strength, some of the coordination, which was wonderful to see. But by the following year, he started to feel weakness and lack of coordination on his right side. The fact is, our medical doctors weren't able to deliver a lot of good news to us over the course of his time in their care. However, when they did communicate with us, it was much different than that initial communication with that first doctor, whose name I don't recall, who in that flat tone had kind of spewed medical jargon. It was a sharp contrast to the thoughtful approach taken by, I know one example with our oncologist, Dr. Robertson. She would say things like, I'm obviously hopeful that the MRI results will show shrinkage or that the tumor is stable. But if not, we now know that proton radiation therapy was successful on his right side, on the right side of his brain. So if the scan does show growth on the left side, if you're comfortable with it, we could look into radiation on the left side. She always had a plan in her back pocket, so that we felt prepared no matter what the news came back from the MRI might show. She didn't sugarcoat the news. She spoke the truth in language that Liam and I could understand. And she always had provided hope with an action plan at the ready. Now you're probably wondering why I'm sharing these stories on a day devoted to the topic of palliative care in the person with cancer. And the truth is, I didn't know the ins and the outs of what palliative care even was until this week when I was asked to come and speak right now. And you're probably wondering, well, that's crazy. My son spent almost 3 years in a cancer battle. How could I not know what palliative care was? And the truth is, because when you look at palliative care, all we saw was the care. Liam's oncology team at Mott and at Beaumont last year, and all last year with Arbor Hospice, provided complete care to both Liam and our family that was so seamless and so out of love that I never distinguished when a social worker would come into the room to visit, or a nutritionist would pop in, or whether he was referred to physical therapy or occupational therapy, or when he received care from his neurologist for seizures, or his nurse practitioner would help clean out his ears or help with making his skin sores more comfortable, or when he needed letters from school for special accommodations, or when we needed to transfer him home and get a wheelchair and medical equipment. I simply just saw the care. In fact, in addition to these things, I saw Dr. Chen at Beaumont, who invited his pediatric proton patients and their families to attend the Russian ballet Nutcracker at the Fox Theater at his own expense. And then he later came to Liam's high school graduation party. He brought him a tie in colors that coordinated with his school colors. We saw a hospice nurse, Jennifer, who made this necklace for me with Liam's heartbeat printed on it. We observed our social worker from Arbor Hospice, Tara, and she often visited us and helped us with networking with other nonprofits as well as their Anchors programs for children, who helped us with some temporal needs while I wasn't able to work, but who also helped to provide some amazing memories that our family will always cherish. The hospice team also helped us to navigate some really tough conversations with my son when he decided that it was time to sign a DNR and stay home for several months. He did so calmly and by making the most of every day. And I saw our hospice nurse, again, Jennifer, who was there moments after my son passed away, allowing our family time to be with him while she took care of the details. She allowed us that time for our final goodbyes. I'm profoundly grateful for the loving care that Liam and our family received throughout the course of this 3-year battle. And I know that if Liam were here, he would want to express his gratitude. He often spoke about how much he admired those that were caring for him. They befriended him. I know that they miss him too. I'm so grateful for the care that was brought out of love, that was so seamless that we didn't recognize or distinguish it as palliative versus any other kind of care that we received. Thank you so much for this time. And we do really applaud and appreciate meetings like these, whose focus is increasing patient care and the quality of it. It's a difficult season for families like ours, and you are all very, very appreciated. Thank you so much. And Dr. Tummel, the time is yours.
Heather, I don't even know how to thank you for sharing your story. I know it goes without saying that being a mom and being able to talk about that, just you're so brave to do it. And I think even those of us who are clinicians that do this day in and day out, hearing the patient and the family perspective is always so incredibly meaningful. So thank you so much for coming. It feels hard to transition to anything else other than thanking you and talking about Liam. But I feel like we will transition, but I know the chat is a nice way for people to thank you for being here and to share their thoughts. I also want to say that your talk was so meaningful to me because you're really presenting what the ideal is, that patients and families just get what they need. It doesn't matter who's giving it to them, whether it's a nurse or social worker or doctor or what their practice is. And I feel grateful that you had a care team that delivered that to you and Liam and your family. And I do think it probably happens a little bit more in pediatrics than it happens in adult care, but I think it's really something that we should all be striving for. And hopefully talking through it with my talk will help us think about how to get there. So again, thank you, Heather. Louise, am I supposed to share my screen now?
Yes, Jennifer, Vanessa will give you, should be stopped sharing her screen. Okay. And you should share your screen now. So Vanessa, can you let that happen?
You're all set, Dr. Tummel.
Okay, this is always the hard part, right? All right, are you guys seeing slides?
Yes, we are.
We are.
Thank you.
I didn't mess anything up.
No.
All right.
Doing great.
It looks great.
Thank you, good. So I'm going to be talking about integrating palliative and oncology care. And I've sort of divided it into past, present, and future. And as I've already alluded, I really think the future is what Heather talked about, the care that Liam received, that we just figure out what patients and their families need and deliver it the best way possible. So for the past, I'm going to start talking about, why did this effort to integrate palliative and oncology care begin in the first place? And then for the present, talk about the status of the field, which is really going to be going through a lot of data. I know going through data is boring, so I will try to make it as entertaining as possible. But I think it's kind of important to know what the status of the field is with respect to the data. And then we'll transition to kind of where the future lies, what more research and what more activities do we need to do to be able to provide patients and their families with the best possible care. So again, to start, why did we start thinking about a possible role for integrating palliative care early in the course of disease for patients with cancer? Now, historically, we know that, the role of palliative care in the hospital or the home setting for patients near the end of life had been established for many, many decades. So in the hospital setting, it's been quite a long time that when patients with cancer or other serious illness were hospitalized and needed help either with difficult physical symptoms like pain or challenging end-of-life care circumstances, that most academic and large community health settings have had inpatient palliative care consult teams to help in that circumstance. And of course, it's been even longer in the United States that we've had hospice to deliver care predominantly in the home for patients who are near the end of life. But we've also known for some time that these inpatient palliative care consultations and hospice care models left many patients with serious illness such as cancer and their family members with a great deal of unmet needs throughout their course of illness. Both symptoms, physical and psychological, but also communication needs. Again, very beautifully described by Heather's story. When there's good communication, you remember it. But when there's bad communication, you also remember it. So making sure that patients and their families are receiving compassionate, supportive care about their prognosis, goals of treatment, and end-of-life care. And so again, stepping back when we're trying to think about kind of what the status of cancer care is and how palliative care can play a role, as a thoracic oncologist, I'm always thinking about patients with lung cancer. So for this example, what's it like for a patient living with a serious cancer like lung cancer? Obviously, with metastatic disease, those patients do ultimately die of their disease. And I would say this trajectory is the same whether they're very ill and live just a few months, or nowadays with novel therapeutics live several years. But we know that most patients with a new cancer diagnosis like metastatic lung cancer have some physical symptoms like respiratory symptoms like dyspnea or cough, pain. And then there's also sort of the psychological components that, again, don't just impact the patient, but also their family, their anxiety, and their worry about the diagnosis. As they begin cancer therapy, even with novel therapies like immunotherapy, patients do have the side effects of their cancer-directed therapy, and they're navigating what the diagnosis and the treatment means for their usual life, their interactions with their family, if they go to school, if they go to work. And then again, when we're talking about diseases like lung cancer that ultimately progress because no treatment works forever, patients generally have increasing symptoms when their cancer progresses, and they need to cope and adjust to the changes in their physical health and functioning. And then of course, as their physical health worsens and they need more help and support, and on the psychological component, as they're facing decisions about end-of-life care. So again, when we go back to this historical role and we think about this trajectory, again, whether it's months or years, and we think about the past and how we provided palliative care, there were often these one or two touch points that maybe if someone was admitted to the hospital for pain, they had palliative care. The majority of patients in the US, about 50 or 60%, do receive hospice care at home prior to death. But this scenario left patients dealing with these symptoms, side effects, declining health status, the psychological anxiety, navigating these changing relationships, and planning for end-of-life care often without sufficient sort of attention or individuals addressing these circumstances. So, usually when this is live and we can do Q&As in an interactive fashion, someone raises their hand and says, well, isn't that the oncologist's job? And again, we just heard a story where oncologists did an absolutely beautiful job doing this. And of course, oncology does their best. Most of us who take care of patients with cancer do so because of the stories we hear, like Heather's. We're drawn to helping patients, and most of us are doing the best we can. But I would say it's only gotten harder and harder over time to be an oncology clinician and be treating patients with the best, most effective cancer treatments, and being able to do sort of all of these additional needs, both in symptom control and in communication. So again, oncology care models are already complex, getting more and more complex by the day. Often our patients are only booked to see us for 15 or 20 minutes, where there's a lot of things that we need to address. We need to look at the genetic and molecular testing. Again, 15 years ago, that was something we just dealt with in lung cancer, but now every cancer is having to look at genetic testing. We have to be thinking about clinical trials and what our optimal treatment regimens are. We have to be enrolling and monitoring patients on clinical trials, which is incredibly time consuming. And then of course, we have to be assessing and managing these treatment-related toxicities and adjusting regimens. So when we think about that, the next thought should be, okay, well, it's hard for oncology to do it all. Let's involve palliative care. So the next thing really is, well, what would we want patients to do? What would we want palliative care to do? And while I only have collaborate in my first point, I think we really want to think about this being, we are one team. As Heather said, we want this to be seamless. We don't care who it is. We just want patients to get the best possible care. So palliative care should be collaborating with oncology to manage patients' physical and psychological symptoms, helping patients and their families cope with serious illness, engaging patients and their families in these difficult conversations, and of course, including the family as a recipient of care, which is something palliative care does do a bit more effectively and seamlessly than oncology does. But again, this has to be in the backdrop of patients receiving the best possible cancer treatment. So again, this is not an either or. This is not palliative care or cancer care. And those of us who are old enough remember this old IOM model that you were either getting cancer care and wait, and then you made a sharp transition to palliative care. That is not what we are thinking is the best way to move forward. That's not optimal care. So again, we want the care to be integrated and seamless and a team approach. And so again, this is kind of the historical model. My PowerPoint skills aren't good, so I couldn't draw it with that beautiful shading that IOM did. But this is sort of that model where it's an either or, your cancer care or your palliative care. And I would say this historical or past model, the pro of it is that it was pretty straightforward. You had an oncologist, then you went on to hospice care. But for those of us who practiced 20 years ago, we know the con was that palliative care was too late and our patients and families were suffering. This is what I would say is the current model that IOM and organizations talk about, is that we know palliative care should begin at the start. But this model, the way it's drawn, that line is intentional, and it implies that cancer care is more important at the beginning and palliative care is more important at the end. And at least it has palliative care in the beginning, so kudos for that. But it sort of makes an assumption that cancer care is more important at the beginning and palliative care is more important at the end. And for some patients, that might be true, but we know for a lot of patients, that's not the case. And so what I would propose, and we'll talk about this at the end, what the future model should be, is really personalized palliative care, just like we do personalized cancer care. No patient with lung cancer is treated the same. It's based on their specific factors. Is that we want cancer care and palliative care to be delivered in a way that's based on the patient's needs. So from a patient and caregiver perspective, this is the holy grail. The challenge of it is, how do we know what patients' needs are and how do we deliver palliative care in a way that is tailored to them? So again, why is palliative and oncology care integrated such a complex model? And those of you who have outpatient palliative care at your institution will be very familiar with this. But for example, who's going to do the palliative care? In the inpatient setting, palliative care includes doctors, nurses, nurse practitioners, pharmacists, social workers. I don't know a single cancer center that's going to give all of those different practitioners all the space they need to take care of patients. So we really have to be thoughtful about who's going to be delivering the care. What are they going to be doing? Again, many oncologists do a fabulous job managing pain. So what should palliative care be addressing when they're involved in patients early in the course of disease? Again, where will they see patients? You know, while our cancer care leadership cares deeply about patients, they also care about money, and we need to think about how do we deliver these services in a way that is acceptable to our leadership, because sometimes these services have different remuneration and billing. How will the patients be scheduled? So even if we have early palliative care, what's the right frequency? How will we be sure that patients are getting the care when they need it, et cetera? So I think these are things to keep in mind as we go through kind of the status of the field and the data and think about moving the field forward. And I'm not going to go through every trial because then you really would be bored with too much data, but I'm going to highlight some of the sort of larger and more paradigm changing studies that have been done, looking at integrating palliative care either early in the course of illness or for situations that we haven't traditionally thought that palliative care would add value to cancer care. And I've sort of divided it up into two arenas. One is outpatient palliative care interventions, and then the second is inpatient palliative care interventions. And in the outpatient palliative care interventions, sort of talk about two models, telephone-based early palliative care models and in-person early palliative care models. So actually our first study ever showing a role for palliative care for patients in the outpatient setting was a telephone-based model. Obviously with COVID, we're all doing more Zoom meetings and more Zoom patient care than we ever dreamed. But when this study was conducted 15 years ago, it was telephone, there were no video visits. And this was a intervention delivered actually not by palliative care advanced practice nurses. They didn't even actually have palliative care advanced practice nurses back then, but nurses that were trained in palliative care. So to some extent, and we'll talk a little bit about this later, this was what you might consider a primary palliative care intervention, where you took clinicians and you did additional training so that they could deliver palliative care. Another unique factor about this study, and again, I'm sorry I didn't mention these are the ENABLE studies by Marie Bukaitis and colleagues, is these are manualized interventions. So again, it's not like for those of you who have palliative care at your hospital where the nurse practitioner comes in and kind of sees what's going on and tailors their care. These were structured, manualized sessions, so more like traditional psychology care. They focused on problem solving, communication, symptom management, and advanced care planning. So for this study, it was monthly calls by these advanced practice nurses. And this was the study design, over 300 patients with serious cancers who were felt to have a prognosis for about a year. And again, randomized to the ENABLE intervention or usual care. On all the studies that I'm going to show, you're going to see that I've sort of divided it into two types of outcome measures. Patient-reported measures, which in my mind are the most important measures, asking patients or their families about their symptoms, their quality of life, their mood, their coping. But most of these studies also looked at things like health service utilization or cancer-directed therapy. So I'll also point those out. So again, these are our most important outcomes, how the patients are doing. And in this ENABLE intervention, the intervention is the solid line and the usual care is the dotted line. And trust me that all these figures are going in the right direction, that palliative care is better. But patients receiving this telephone-based manualized intervention had better quality of life, lower depression, and certainly a trend towards lower symptom burden. However, when we looked at the measures that they looked at for sort of communication, healthcare utilization, either in their full study cohort or their deceased cohort, the patients who died during the study, no difference in documentation of end-of-life care preferences, no difference in referral to palliative care, because again, this wasn't a traditional palliative care intervention, and no difference in resource utilization. So normally, if we're in person, I ask you what you think the take-home points are, but we can't do that. So here are my take-home points, is I remember when I read this paper for the first time and I thought, geez, all we had to do was call patients on the phone and give them some strategies to communicate and address their symptoms, and we can make them feel better. That's number one, incredible. But number two, this is such low-hanging fruit. These patients are really suffering. And it's actually not that hard to make things better for them. So again, this was really our first proof of principle that early attention to palliative care improves outcomes for patients with cancer. But as I showed on the last slide, this telephone-based intervention wasn't intensive or sufficient or meaningful enough to impact healthcare utilization and communication or delivery of end-of-life care. So that brings us to our in-person outpatient palliative care models. And I'm going to talk about two that are very similar. Both of these models involved in-person palliative care with a physician or advanced practice nurse at least monthly. The model that we've studied at MGH, which we sort of have coined early integrated palliative care, was for patients who had a new diagnosis of incurable cancer, and they saw palliative care monthly from diagnosis until death. My colleagues in Canada, Camilla Zimmerman, did a similar intervention for patients who had a limited life expectancy, and they had a 4-month palliative care intervention. So again, in-person visits monthly for 4 months. In both of these studies, patients who were receiving outpatient palliative care, if they happened to be admitted to the hospital while they were receiving the intervention, the inpatient palliative care team saw them as well. So this gets back to that slide where I talked about how complex these models are. So this kind of operationalizes how we've built our model at MGH. So again, many types of clinicians provide palliative care in the inpatient setting, but to think about how to streamline it in the outpatient setting, our palliative care visits are conducted by physicians or advanced practice nurses. The needs of patients with cancer are so varied. We really did not feel like providing a manualized intervention was the right strategy. We want this palliative care to be tailored to patients' needs. So it really was flexible so that the palliative care clinician could address what they thought was most important to the patient and their family. The other thing that we've done, and again, this is really a technical challenge, one might say nightmare, is trying to schedule palliative care visits on the same day as oncology visits. Patients don't want to spend extra time in the cancer center. They want to be at home with their family doing fun things. So we've tried to arrange it so that patients see palliative care the same day as oncology care. And it's hard. Those are already long days. Patients come in for labs, they have to see the doctor, they go to the infusion room, and adding a palliative care visit on. But that's how we've sort of operationalized this care model. So this was the first study that we did in patients who had metastatic non-small cell lung cancer. And again, when we started this study, 15 years ago, the median survival of this patient population was about 8 months. Again, very different today, but that's what it was then. And I'm going to quickly run through some of this data. So we showed that patients receiving the early palliative care model had better quality of life. This was at 12 weeks, because again, after 12 weeks at this time, it was hard to collect data from patients because their health was already declining. We looked at 2 measures of depression. One is called the HADS, the other is called the PHQ-9, and you can see in pink, patients receiving early palliative care had less depression. No difference in anxiety. We also showed that over time, patients who were receiving early palliative care, shown in this gold color, were more likely to remain or become accurate, stating that their cancer was not curable. And the reason we started looking at these measures is we know that how patients understand or perceive their diagnosis and prognosis directly translates into the decisions that they make about their care. And we got some inklings of that because we did see with this early palliative care model, patients were more likely to have a documented code status, meaning they engaged in an end-of-life care conversation. And although the majority of our patients died at hospice, you can see that hospice length of stay was much earlier for patients receiving palliative care. And again, we know that that's a key quality metric. And patients receiving palliative care, again shown in gold, were much less likely to receive chemotherapy in the weeks and months prior to their death. As a follow-up study, we did a larger study, also in patients with lung cancer, but we added patients with serious GI cancers. So we included all GI cancers except colon cancer, since at that time, again, that population had a much better prognosis, and did a very similar study. Although, again, we were learning a little bit more about how important prognostic awareness and coping was. And we also wanted to know if this model would improve family caregiver or family or friend caregiver reported measures. So I'm just going to focus on some of these new outcomes of the study. So we did find that early palliative care was helpful for patients to know about prognosis, to make decisions about treatment, and cope with their illness. And then the second part of the slide, patients receiving early palliative care were about twice as likely to say that they engaged in an end-of-life care conversation. So some new metrics which are really encouraging about this care model. This slide actually shows our family caregiver reported outcomes. And we found that the caregivers of patients receiving early palliative care were less likely to feel distressed looking at a measure called the HADS. So again, sort of our first inclination that involving palliative care early for patients also improves the experience of their caregivers. So the last outpatient study that I'm going to talk about very quickly is this Canadian study. As I said, it was very similar and frankly showed very similar outcomes, improved quality of life, improved symptoms burdens. They had an additional measure of satisfaction with care that was also improved with palliative care. So that was a lot of data. So we'll all take a deep breath while I summarize the take-home points from these. So my take-home point is similar to the Enable telephone-based intervention, in-person palliative care improves patients' quality of life, mood, and symptom burden. And unlike Enable, these early longitudinal, more intensive, more involved, more intimate relationships with palliative care also improves communication about and delivery of end-of-life care. But one of the things that I implied at the beginning is these care models are incredibly complex. They are very hard to pull off. They are frankly today, 20 years after starting this research, they are hard for us to do at MGH. Finding the space, doing the scheduling, collecting the data. And it's very hard at new institutions that aren't used to this model. And a sort of exemplary of why and how these are so complex is after that last study, I collaborated with the NCI Alliance group to do an identical study across the NCI Alliance, where we involved 10 academic sites and 10 community sites, randomized patients to integrated palliative care or standard care. And we thought this was a slam dunk. We were like, this is gonna go great. We've learned how to do this. We know how to do this. These 20 sites are gonna pull it off. And that is not what happened. So this slide shows the palliative care visits for the first 24 weeks of the study, usual care in blue, early palliative care in orange. Patients were supposed to be seen monthly, but we all know that, sometimes the patient's hospitalized or misses a visit. So we wouldn't necessarily expect every patient to have, the 6 visits they were supposed to in the 24 weeks. And here what you can see is about half of the patients or so had 5 or more visits. But you kind of look and you say, well, there's a lot of patients assigned to early palliative care that really had no visits, even though they were supposed to be seeing palliative care monthly. Now, if you compare that to one of the studies that we had done previously at MGH, where we had a lot of experience doing this, so really knew how to get patients scheduled for their palliative care visits, you can see that 75% of patients had 6 or more visits, and hardly any patients had less than 2 visits. So the concern when we looked at this data was, were these patients really getting the early palliative care as we expected or as we had proposed? In addition, we learned that it's really hard to collect data from patients, that many sites don't have experience asking patients to complete patient-reported measures. And so in addition to challenges with delivering the intervention, we were missing tons of data. And of course, what that led to is a negative study. All the trends in the right direction, like quality of life was close, anxiety was close, but because patients didn't get the intervention and we didn't measure their outcomes, this was a negative study, which really highlights how difficult these models are to implement. I'm sure that'll be a point of discussion, so I'm ready to come back to that as well. So now moving on to our inpatient palliative care interventions. So in the inpatient setting, these have all been in-person models. And you might be thinking, well, you know, Jennifer, you talked at the beginning, like palliative care started with in-person, inpatient, there's a lot of ins there, inpatient models. Why is this innovative? And so inpatient palliative care still today at most institutions is really for patients near the end of life. Number one, when solid tumor patients are admitted to the hospital, they are mostly in the last weeks and months of life. And so inpatient palliative care really kind of remains with that historical or past model. They're seeing patients for uncontrolled symptoms or for difficult end-of-life care situations and not really having an impact on the patient's quality of life or their long-term outcomes. And so what we wanted to do is think about how do we involve inpatient palliative care for new populations in a way that we can really have a durable and meaningful impact on their quality of life. And so our sort of tactic has been, well, geez, who are the inpatients outside of solid tumor patients who kind of have the roughest time, who have the greatest symptom burden, who get the most difficult chemotherapy? And I think the patient population that comes to everybody's mind is patients getting stem cell transplant. You know, those patients get incredibly intensive chemotherapy. They're in the hospital for weeks. They feel pretty terrible. So when we wanted to think about a population to start this kind of innovative early palliative care in the hospital setting, this was our first study. So we looked at patients admitted for transplant and again, randomized them to the palliative care intervention or usual care. For our palliative care intervention, these patients tend to be in the hospital for about 3 or 4 weeks. So we asked palliative care to visit them in their hospital room twice weekly during the transplant. One thing for you to know is this was only an inpatient intervention. So after the patients went home at about 3 or 4 weeks, they never saw palliative care again. So this is the primary data, and just to orient you, I put some little circles. So this is the 2-week mark on all of these figures. These are when patients feel the absolute worst. They have no blood cells, you know, they're really nadiring, symptom burden is at its highest. 3 months, they've been home for about 2 months. And so what you can see in panel A is quality of life, panel B is depression, C is anxiety, and D is symptom burden. At the 2-week mark, palliative care, which is shown in the darker circles, and again, trust me, they're all going in the right direction, that it was better. All of these metrics were significantly better at 2 weeks. So again, these twice weekly palliative care consults improve patients' quality of life, mood, and symptom burden. What's amazing though, is at 3 months, these patients hadn't seen a palliative care provider in 2 months. All they had been seeing was their oncologist, but for quality of life, depression, and anxiety, the impact that palliative care had during the transplant was sustained. This brief palliative care intervention led to long-term improvements, not just at 3 months, but when we looked 6 months status post-transplant. So again, these patients hadn't seen a palliative care clinician in 5 months. 6 months post-transplant, significantly lower rates of depression and significantly lower rates of PTSD. So again, brief interactions at high risk times can have a durable impact on a patient's health. So we were so excited about this data for patients with stem cell transplant. We went to another population who again really experiences a great deal of suffering, and that's patients with AML who are receiving intensive chemotherapy like the 7-in-3 regimen. So that was our next study, very similar study, very similar intervention, but for patients who were receiving AML. In this population, though, we know that they spend much of their life in the hospital and tend to be readmitted multiple times, especially over the first year. So for this intervention, every time the patient was admitted after their intensive chemotherapy, we did ask palliative care to see them with these twice weekly visits. So this is a very similar slide. In panel A is quality of life, B is anxiety, C is depression, D is PTSD. The intervention is shown in orange. And again, all of these lines are in the right direction, that there was early and sustained improvements in all of these outcome measures with involvement of palliative care. This study actually just completed, so we're still analyzing some of the data, but this slide shows you some other changes that we saw that's actually similar to those outpatient palliative care studies. So palliative care is shown in orange and usual care is shown in blue. And you can see that patients receiving palliative care were much more likely to state that they had discussed their end of life care preferences than patients receiving usual care. And they were significantly less likely to receive chemotherapy in the last months of life. No difference in hospice use or hospitalizations, but I think the communication and chemotherapy data is quite compelling. So my take-home points from these studies is that palliative care also improves outcomes for patients with hematologic malignancies being treated with curative intent, and that even brief or short-term exposure to palliative care can have an impact on late outcomes. So to sort of summarize the present or the status of the field, transitioning palliative care from the hospital to the outpatient setting is an effective care model and dramatically improves the experience and outcomes for patients with serious cancers and their families. We also now have data that involving inpatient palliative care for patients who are hospitalized during very high risk periods, such as with leukemia or undergoing bone marrow transplant, also have improved experience and outcomes with early palliative care. So you might be thinking, all right, great, we're done, like nothing more to do. But that is, I guess, unfortunately not the case, but fortunate for those of us who do research because we have some more work to be done. So I would say not so fast. There really are a lot of unanswered questions about how we should be delivering palliative care to patients with cancer. So first, we lack data on the nature, the timing, the dose of palliative care across populations. So you might be thinking, in your first lung cancer study, why did you ask palliative care to see patients every month? And my answer to that would be, I made it up. I guessed. I didn't know. But maybe that's not the right interval. Maybe for some populations that's too much, for some it's too little. Also, what is palliative care really doing? We have to have a better understanding of that and think about, does everybody need exactly the same thing? Now that is in the backdrop of cancer care is changing by the day. So these studies that were done 10 to 15 years ago, do they still apply? Do patients on targeted therapy for lung cancer like Tagrisso that doesn't have a lot of side effects and toxicity, do they really need early palliative care? And probably an equal barrier is that we have inadequate space, resources, and frankly, palliative care clinicians to see all of these patients that would benefit from their care. So now we're transitioning to the future. So I'd say the future of palliative care is trying to answer some of these questions. And I have tackled some of them in my last slides, but if people have others, we can talk about them during the Q&A. So I think one kind of burning question in the field, and Diane Meyer from CAPC sort of coined this, is what's in the palliative care syringe? What is palliative care doing? And over the last 10 years, our team has really tried to get at this question. And frankly, the answer was a little bit surprising. So in one of our studies, we basically asked palliative care to document what they did for the first 24 weeks. So again, in those 6 first visits, we looked at what is palliative care doing? Now, not surprisingly, 75% of the time, they're talking about symptoms. That definitely wasn't surprising. But it was a little surprising to see that almost an equal amount of time they were spending on coping. They're not psychologists or social workers, but why are they spending so much time on coping? And we actually looked at what they were doing across the patient's life. So again, this is kind of looking at initial visits and the visits prior to death. Again, they are addressing coping throughout the course of illness. And again, this was somewhat unexpected to us. So we thought, wow, if palliative care feels like they're really spending so much time addressing coping, maybe coping is what's in the palliative care syringe. Maybe this is really the value add of palliative care. And so if there's any statistical minded people on this call, you probably really like these slides. I'm not statistically minded, and these mediation slides like make me sweat. But what these slides show us is that it's the improvement in coping that actually drove patients' improvement in quality of life. Amazing. Like, it wasn't the physical symptoms, it wasn't that we were managing their pain better, is that we helped them cope with their serious illness. That's what improved their quality of life. But probably even more amazing to me is it actually drove their improvements in their mood as well. So coping is a big part of what is in the palliative care syringe when we bring palliative care early in the course of disease and integrate it with cancer care. But I would say it's not the full answer. So I am going back to that study that I talked about that we did at MGH, where we looked at lung cancer patients and GI cancer patients. Now, on the left side of the screen is the lung cancer patients. The top panel is quality of life, and the bottom panel is depression. And that looks very similar to that initial New England Journal of Medicine paper. Patients getting early palliative care, they had better quality of life throughout the course of illness, they had less depression. Done. But when we looked at the GI patients, we gave a big uh-oh, because that does not look the same as what's happening in GI. Certainly when we get to week 24 and when we looked out further, it was the same pattern, that quality of life and mood was better. But smack there in the middle, palliative care was not helping these patients with pancreatic, esophageal cancer. What went wrong? I can't answer that question. I'm not sure what went wrong. But I would say these are probably not one size fits all models. And for those of you who take care of patients with GI cancer, you know that they actually have a lot more physical symptoms than most patients with lung cancer. They're often admitted to the hospital for things like G-tubes and procedures. And so maybe monthly outpatient palliative care wasn't enough. Maybe when you're admitted to the hospital and you're getting a G-tube place, coping's the least of your problems, and we should have been focusing on other things. So I'd say, to me, this is an example of we really need to figure out what a patient and caregiver population needs and try to sort of tailor our interventions to their specific needs. Again, this is all in the backdrop of cancer care is changing by the day. And again, since these studies were conducted, we now know that many patients with serious advanced cancers aren't treated with chemotherapy. In lung cancer, we have lots of patients who receive immunotherapy alone or targeted therapy, and maybe those patients don't have the same palliative care needs or even need palliative care. And then, of course, when we think about end-of-life care, many of these patients are living years and years. So certainly a model of monthly palliative care from diagnosis to death just doesn't make sense. But I would also argue that these novel therapies bring about a whole new bag of palliative care challenges. So this was a study published by one of my colleagues who was like a genius scientist of studying molecular therapy. And the paper was about the amazing science. The paper was about that this young woman who had young children at home, who had an ALK translocation, every time her cancer progressed, the really smart team was able to do a biopsy and find another mutation and give her another targeted therapy. And every time they did this, her cancer responded. And it was all about how amazing the science is. And if we just biopsy people and targeted them, everything's all good. But when you actually talk to this patient, every time her cancer grew, she was on the verge of death, was admitted to the hospital, said goodbye to her children, left her job. And then every time they did a biopsy and started her on new therapy, she was like, oops, I'm still here. Would have like a period of months where she went back to her normal life, went back to work. And that cycle happened over and over and over. Now, at the same time, for being grateful for all the time she had by her excellent team, that pattern of getting so sick, almost dying, brought back, was actually really difficult for her. And what they didn't talk about in the New England Journal of Medicine paper was if you look at the far right and you see where they did that last biopsy and nothing happens, is at that last biopsy, they found another targetable mutation and had another oral therapy available for her. And she said no. She said, I can't do this anymore. So again, are things different now with targeted therapy and immunotherapy? Absolutely. But I don't know that the palliative care needs have gone away, but they're probably different. And so with these novel therapies, maybe patients do have less physical symptoms, but patients still need support coping, because whether you live 6 months or 6 years, living with a life-threatening illness is incredibly hard for patients and their families. So I would argue palliative care will still need to play a significant role, helping patients manage the uncertainty about their future and the distress associated with it, and maybe need to play a greater role in end-of-life decision-making. But again, this sort of field of integrating palliative care in the novel therapeutic era is certainly at its infancy. So again, I sort of alluded to this at the beginning, but I think the way we need to be delivering palliative care is in a patient-centered fashion. And I actually stole this diagram from my basic science colleagues who use it to talk about using mutations and targeted therapy for patients. But I think we should be thinking about palliative care in the same way. We need to look at the patient population. We need to look at their symptoms, both physical and psychological, what their experience is like. Do they spend a lot of time in the hospital? Do they have a lot of physical symptoms? And target the palliative care to these needs. So to me, the future of palliative care is really trying to figure out how to deliver it in a patient-centered fashion. Now, the second problem we talked about was inadequate palliative care staffing and resources. And to some extent, this is our biggest problem right now. So no matter how well we can deliver patient-centered palliative care, if we don't have palliative care clinicians to deliver it, we don't really have anything going on. So this is really important and is becoming increasingly important, because I think we've all seen during the COVID pandemic that our palliative care clinicians were really called upon to go to ICUs and go to the emergency room to try to help patients make these decisions. And we just simply lacked adequate clinicians. So as I shared, when Heather shared her story, there's been a lot of interest in whether we can increase what's called primary palliative care skills. So basically, take me, I'm not palliative care trained, I'm just an oncologist. Can you send me to some training sessions and do some extra education with me so that I can learn these skills, so that seeing just me would be just as good as having a specialty trained palliative care clinician involved? I would say the second strategy really ties on to that patient-centered model, is can we deliver less resource-intensive palliative care models using novel technology so that palliative care isn't running around so much and having to be in the cancer center and the ALS clinic and the CHF clinic? And can we triage services to those who need it most? For full disclosure, we don't have much data on either of these care models, so this part is a little bit more thought-provoking, but two studies that I want to talk about. So one is the Ariadne lab, which came from Atul Gawande's work of using checklists, is serious illness communication. And I want to talk about this because I'm sure many of your hospitals have implemented this serious illness communication or serious illness care models. And these are, to some extent, primary palliative care models. So can you take oncologists, emergency room doctors, cardiologists, train them to have these conversations with patients that they don't normally have and have it improve patient outcomes? So this was the first study by the Ariadne lab looking at this in patients with cancer. They chose two really hard measures for their study. They chose goal concordant care, which means patients received the care that they said they wanted. That is a really hard thing to measure and a really hard thing to look at. And then they used a patient-reported outcome called the peace scale, which sort of measures how content and satisfied and at peace people were. And unfortunately, they didn't show any impact on either of those measures with their intervention. But if you look at the bottom of the slide where it says figure 2, in the middle and to the right, patients who were receiving the intervention had lower rates of anxiety and depression. So maybe having these conversations with patients earlier did lead them to feel less worried and distressed about their diagnosis. So again, even though the primary outcome was negative, there was a lot of excitement about this as, again, a proof of principle. We can train people to do a better job. There's been another study looking at this. I think we're a little less familiar with it in the oncology space because this study included patients with a variety of serious illness. This was done by my colleague in Washington, Randy Curtis. This was called the Jumpstart intervention and gave patients' information and questions about what they value and perceive, and then gave that information to the physicians, and the physicians had some training. So again, a primary palliative care intervention, but also really encouraging patients to think a little bit about their goals and values. Now, to some extent, we have opposite results here than we had in the last study, that you can see that the intervention, which is in that darker blue, they actually did show improvements in goal concordant care, which again is incredibly impressive. That is such a hard measure. But opposite to the previous study, no difference in depression and anxiety. So again, this field is in its infancy, but some indication that we can do some training with clinicians to at least do the communication piece and communicate with patients and their families about some of these difficult topics. So again, my take home from this, and I think this would be a great thing for us to discuss at the end, with training and support, there really should not be a downside to training oncology clinicians. You know, we're not going to make them worse by having them do training in serious illness communication or anything else. So I don't know that I need a lot of data to tell me that this is a good thing. There's never going to be a bad thing to training people. But whether it's going to be equivalent or as good or better than palliative care, no, I don't know that. We really have the mixed results from these early studies. So I think we really have to kind of wait it out and figure out how much can be done. My best guess is that, yes, these primary palliative care models will help, but we'll still need specialty palliative care for patients who have additional care needs. The very last two things I'm going to talk about are these less intensive palliative care models. And for this part of the talk, I actually have no, oops, I'm dropping things. I have no data at all, but I'm just going to tell you about some research that we're doing to answer these questions. So again, very quickly. So the first is looking at whether we can use telehealth to deliver early palliative care, because telehealth does require less resources, less space, less time, less burden for clinicians. Now, you might all be thinking, why is this interesting? Since March 2020, all we've been doing is telehealth. Well, this study started 2 years before the COVID pandemic, so it's become a little less relevant right now. But we are doing a study looking at whether telehealth video visits for palliative care is equivalent to in-person palliative care. The study will enroll about 1,250 patients, and we've enrolled about 650 patients so far. Obviously, it's been a little tricky during COVID. So this will be forthcoming. And then another care model I just wanted to mention, because again, this is a care model which has been shown to be really effective for other types of supportive care, such as psychology care, social work care, is what's called a stepped care model. So sometimes stepped care models are part of collaborative care models, and sometimes they're not. But basically what it refers to is that every patient gets some low-level specialty care by the mental health clinician, or in this case, a palliative care clinician, and you monitor patients to make sure that that low-level or low-intensity care is helping. And if it's not helping enough, patients, quote unquote, step up to the more intensive care. So we developed a stepped care palliative care model, where again, everybody sees palliative care at key points: diagnosis, after hospitalization, after progression. So low level, not monthly, to minimize palliative care resources. But we monitor patients very closely. And if their quality of life drops, suggesting that that low level touching isn't enough, they step up to monthly palliative care. So that study is ongoing and should be done in about 1.5 years. Also slow during COVID. Welcome to our lives as researchers during the COVID pandemic. So in summary, the role of early involvement of palliative care for patients with newly diagnosed, poor prognosis cancers, or those undergoing intensive inpatient treatment is now established. That's our current. We have this data, clear benefit for palliative care. The challenge is that despite this data, implementing these care models is challenging. We couldn't pull it off in the Alliance Palliative Care Study. So when we think about kind of smaller academic institutions, community sites pulling off these care models, it's really, really difficult. From a research perspective, we need to focus our efforts into how to develop more patient-centered palliative care models that are scalable and disseminable, so that we can increase access to this care, but make sure we're delivering it in a way that patients and their families need. And then last is just my thank you slide. So I will stop sharing my screen so we can do some discussion. There we go. Awesome.
Thank you so much, Dr. Temmel. That was terrific. There's a lot of activity in the chat, and Dr. Emily Mackler is going to moderate a Q&A, and then please feel free to add more things in the chat or to unmute yourself, but we'll go ahead and turn this over to Emily.
Thank you, Dr. Griggs, and thank you, Dr. Temmel. I've had the privilege of hearing you speak before, and so it's been wonderful that you could join our group and I could hear you again. We do have a couple questions that have come up in the chat while you were speaking, and I'll share some of those. And for the audience, just so you know, I'm still monitoring the chat, so feel free to bring things in and you can assess me on my multitasking. So one comment or question that came up was how often in palliative care are the goals of care being discussed in what you saw as exceptional responders?
That is a great question. So I would say in exceptional responders, we probably, haven't looked specifically at them, but who we've looked at is patients who we know have a better prognosis. So we've looked at patients with these targetable mutations who tend to have a longer survival. And I think, the goals of care conversations in all patients, even with palliative care, tend to happen after palliative care has established a relationship or rapport with patients. But not surprisingly, in these patients who do better, and I guess officially are exceptional responders, palliative care does have these conversations later, and they really do struggle with how to deliver end-of-life care. And I think that example that I showed of that young woman who kept getting biopsy and getting treatment, it's just hard for palliative care to know when there's going to be another treatment. So one thing I didn't talk about in this talk is, if we really want the teams to be collaborating and care to be seamless, it requires really good relationships and teamwork between palliative and oncology care. So I think with these patients who have these novel therapies or exceptional responders, palliative care really has to rely on oncology to let them know when there are more treatments to enable palliative care to do their work. So again, I think this is something that really does require more exploration.
Great, thank you. Another comment that came up, or some questions, was the aspect of thinking about, particularly in the outpatient setting, that aspect of resource, and that often time spent within these palliative care discussions and care that's given, if done by the oncologist, often is quite time limiting. Can you comment for our group, especially knowing the varying sizes of practices and a significant amount of community practices that we work with across the state, how has this model relied upon or utilized other interdisciplinary members of the oncology team to help advance the palliative care choices or education provided to and working with patients?
Yeah, I think that's a great question. And a little bit comes back to how we started this. We were talking about Heather's experience. I don't mean to be flip, but I don't care who does it, as long as someone does it and they do it well. So often I get asked this question because a lot of care practices around the country, social work has taken a lot of ownership over this. Now, it just happens to be that that's not the model at my institution. But if you work at an institution where you have social workers or nurses or chaplains, or frankly, volunteers who are comfortable having these conversations, they're good at it, they're compassionate, they're supportive of patients and their families, my response is go for it. I don't care who does it, just do it. And so again, I think at some community or smaller academic site, it's a very different care model than at Mass General or University of Michigan. So I guess I would empower everybody, go back to their sites and say, who enjoys this work? Because you got to enjoy it or you're not going to do it. And who wants to do it? And are there additional training opportunities that we could provide for a physician, a nurse, a social worker to help them become more expert? And then let's figure out how to integrate them in the care. So I don't think we should be thinking of silos across discipline, silos across type of care provider. And I think that is just empowering people to say, use the resources that you have to figure out how to give patients and families the best possible care.
Thank you. That's really helpful. One other question from the audience was, in your work looking at palliative care and the outcomes that we're seeing with patients and their caregivers, was there any study or assessment related to what the patient's confidence in self-care was following your palliative care interventions?
It's a great question. So I think, in research, we often call that self-efficacy. And that's a common measure in a lot of psychological interventions. It's something that we haven't included in most of our palliative care interventions. And certainly something to think about. What we always kind of are balancing is burdening patients with too many questionnaires, but I think it's a great point that it's probably an outcome that we would see improvements. That's a great suggestion.
Great, thank you. I wanted to pause from some of our audience questions and see if members of our patient and caregiver panel would be interested in commenting or sharing some of their takeaways from your discussion. We saw a lot of comments from our patient and caregiver panel while you were speaking about things that resonated with them and experiences that they had related to some of what you presented. I'll pause just for a moment to give them the opportunity to speak if they're so comfortable in doing so.
I'd love to hear from Cynthia or Amanda. I think everybody has the ability to unmute, yes? Yep, Louise is saying yes.
So I really have a couple of questions yet. Are we still on the Q&A or?
Yes, we are, Ernie. We were just asking if our patient and caregiver council members would like to add comments or ask questions.
Okay. So my question is, there's 2 or 3 tiers of extended caregivers. I'm not talking about the social worker, the providers at home, but the family first-degree caregiver, such as Heather, and also the extension of that caregiver to the rest of the family members. Do we have any study as to the impact of palliative care to these first tier or the second tier, et cetera, caregivers, i.e. family mostly? And my second question is, realizing that we have to justify our caseworkers, the new E&M coding system for 2021, for additional billing situation, there is a level of complexities, I'm sure, in the problems addressed, and that is whether it is of low, moderate, or high degree of involvement, and you could actually see if that is being done at MGH. And the new coding system just came out about a month ago. So those are my 2 questions.
Yeah, I think your first question is incredibly important. I think in oncology, we probably focus on the caregivers more than a lot of other medical specialties. And I think that's a little bit of a luxury we have, because in oncology, pre-COVID, most of the time family accompanied patients to visits, where like in other disciplines, like, you don't go to your primary care physician as much with your family member. So I think attending to families and their needs has always been a focus in oncology, but I would say not enough, right? Like you might look at the caregiver and be like, how's it going? How's work? How are the kids? And then you focus your attention to the patient. So the palliative care training model, and I don't know if we have any palliative care trained individuals on this call, but if we do, I'd love to hear from you. They really view care differently. So again, the traditional medical training is we focus on the patient and hi, caregiver, but palliative care really views the family as their unit of care. So I do think that's why we do see some caregiver improvements with palliative care. So definitely some early studies showing improvement in caregiver distress, and we've included caregiver measures in many of our studies. So again, I do think palliative care improves caregiver outcomes, but I would say it's probably not enough. I think we need to be doing more care, support, and education for caregivers. And again, I think we need to think about more ownership for that. I still think on the oncology side, forgetting about palliative care, there's still too much of a tendency to defer caregiver support exclusively to social work. And obviously social work does an amazing job. It's not that, but I just think we need to think about how do we better support our caregivers, both during the patient's illness and during the bereavement phase. You know, if patients did receive hospice, often that's provided by the hospice service. But if they didn't receive hospice, most of our hospitals really don't have a lot of bereavement support for caregivers. So I think that's something that we should really be focusing on. Your second question about billing. Billing is like, I've been doing this for 25 years. I still don't understand billing. And so I just finished my training for the new billing system. And I would say my interpretation, and I could be wrong, I could be audited tomorrow and like fired, is that the new billing system is actually more beneficial for these conversations, because the new billing system saying like, hey, if you have a patient with a serious illness, cancer, and you're talking about anything about treatment or end of life care, that's actually high medical decision making. So I actually feel like these new billing codes actually will enable and encourage and allow more serious illness communication with patients and their families. So I felt like it was a favorable change. But again, definitely, Jennifer, you probably know more about this than me with your health services research background.
Well, thank you for that, Emily. I think somebody else had a question. We were gonna, I think.
Hi, Dr. Tummel, this is a wonderful presentation. I'm actually a palliative care health services researcher, and I actually started my career out as a volunteer at Arbor Hospice many, many years ago here in the state of Michigan. This is a wonderful presentation, and I think, you know, one thing that strikes me is that there's been federal legislation called PCHETA, P-C-H-E-T-A, that has had really robust bipartisan support, and it has repeatedly sort of failed to pass the full Congress. It's passed before the House, then failed in front of the Senate. And I'm just wondering, what can oncologists, palliative care providers, and communities do to help support that legislation, to support widespread primary palliative care education and skills training to more providers? You know, I think certainly it would have been a wonderful thing to have prior to COVID-19, but now that COVID-19 is here and we have a new Congress, and hopefully if all goes well next week, a new administration, I'm just really curious to hear what your thoughts are.
Yeah, so I would say also not my area of expertise, but I know that this is something that CAPC, the Center to Advance Palliative Care, and Diane Meyer has been incredibly, incredibly invested in. And I know CAPC has been involved in this intimately for many, many years. So I think CAPC is at least a good place to start and see what resources are available. But I don't know if folks on the call have other suggestions.
Jerome, did you want to chime in?
Yeah, let me just put on my video.
Yeah, we want to see you.
No, you don't. So the first of all, Dr. Tummel, that was a wonderful presentation, and you've done exactly as I had hoped you would when I suggested you come to talk to us, because there's so much meat here that we could spend days talking about. And I am palliative care hospice trained, and there are many questions that I have, and I don't want to monopolize it. As far as the PCHETA, I mean, as Chitra talked about, and it does have a lot of support, bipartisan, and unfortunately, I think it does get sidetracked. I really don't know why the Health Committee has sort of, and again, with the change in the leadership in the Senate, this may now gain some traction that we didn't have before. And I'm hopeful that with the new Congress starting, that we'll see this moved up quickly. So, and I'll keep my fingers crossed, but you know, I'm with the office right now in Senator Rosen, and she's on the Health Committee. She's on the Comprehensive Care Caucus. She's one of the co-chairs. So we are looking at that legislation, and it's going to be reintroduced very shortly, probably within a couple of weeks. And so you'll be hearing about it. And I would say what we can do as oncologists and as palliative care providers is write letters. Being in an office right now, listening to how the senatorial office is run, your voice is heard and you need to use it. Every week we hear from the constituents who are lobbying and writing to the senator from Nevada, where she is representing. So use your voice. When ASCO and ASH say, hey, lobby and advocacy days, get involved, because this can get done. And I think within the first 2 years of the Biden administration is probably the best time. So the iron is hot, and I would say now's the time. So.
Thank you so much for that, Jerome. We look forward to the end of your sabbatical and having you present to us.
We did have a few more questions that I'll start with. And then I think just to get people thinking, we also have members of our hospice communities on this meeting and call. So I'm going to ask a couple additional questions, but I'm hoping that you will be able to share your input, questions, or comments that you may have related to Dr. Tummel's presentation. One question that we had that came up, Dr. Tummel, was related to the care for physicians as it relates to palliative care. Do you have any comments related to that or experience within your work that you can share with us?
I love that comment. I saw that just pop up and it just made me happy. And I'm always sad, to Jerome's point, that I don't get time to talk about all of the aspects of this, because I think one aspect, and from a research perspective, again, I'm sure people on this call would have better ideas than me because it's not what I do research-wise. But, the relationship between oncology and palliative care is one that really warrants some study. And, you think about it, when you have doctor-patient, oncologist-patient, of course, there's a family and everything else, but now you're adding a third triangle. And it's not just how palliative care is interacting with the patient, but palliative care is interacting with oncology. And I would say one thing that I really value when palliative care is taking care of my patients is that kind of team sense for me as a clinician. So when I'm feeling unsure, which doctors feel unsure all the time, I always say, medicine is not a science, it's an art of what to do and what's best. And then even more importantly, when I'm feeling sad, which as a thoracic oncologist, I feel sad and loss and grieving all the time, of having a colleague who shared in that care of the patient, who got to know them as well as I did, got to know their children and their wife as well as I did. That is a huge part of this. And I do think it's a huge part of my resiliency. And we know that our resiliency helps our care for the next patient. So again, I do think this care model isn't just about caring for the patients. It's allowing me to be able to do my job, taking care of a very medically ill population where I unfortunately have a lot of death and dying, but to be able to get through it and give the next patient all I can as well. And again, I wish I had data to support what I'm saying, but it's just more my experience that having the palliative care clinician next to me as a friend, as a colleague, as someone to share the experience with is frankly life-changing.
I just want to point out that question came from one of our caregivers.
Oh.
And I know that people, our patients and caregivers worry about us. So knowing that we get refueled and our resilience can grow through our community, I think was a wonderful question, Cynthia.
Jennifer, actually both of you, Jennifer, I have a question, and I don't know if there's an answer. Because I'm palliative care trained as well as an oncologist, I tend to do my own palliative care. I don't do hospice care per se, although I have that role, but I tend to do all of my palliative care, and I don't mind these conversations. I think and Dr. Balqueva's question alluded to this a little bit. Number one, do you think that the idea of a palliative care team cements this fragmentation of care which we complain about? Because within your institution, you have a team that knows you, you have a relationship, and therefore the communication back and forth may be facilitated by that. In the community, these types of interactions may occur in geographically distinct places, and therefore the communication may be lost. The next question is, what do you understand about insurance coverage for same day visits between the oncologist and the palliative care team, because that may be a significant between geographic time constraints, all of that for the patient who don't want to travel back and forth and back and forth. There may be financial difficulties with doing same day visits like that. What's your understanding?
So for the first question, I guess my first answer is I'm not palliative care trained, but I'm probably as close to being palliative care trained without being palliative care trained as you could be. And I agree, like I became an oncologist to have these conversations and do this type of care. And as much as it sometimes hurts me to say, because I feel like I should be able to be all a patient and their family need, I still think my patients benefit from having someone else. And I think the someone else question is key, because no matter how warm and great and supportive and all those other superlatives I can be, like, I still hold the chemotherapy key. And I think that is complex. It's complex even in patients with great illness and prognostic understanding who, are clear that they don't want treatment when it's not going to help. I think it's complicated when you are the treater. Mm-hmm. I do have a lot of friends and colleagues like you, Jerome, that are dual trained, and many who practice in palliative care and practice in oncology. And they kind of say what I'm saying, that they feel like they're probably better oncologists because of their palliative care training, but they do feel like their role and their hat when they are with patients is different. Toby Campbell, who some of you might know at University of Wisconsin, I love him. He's like, I go from palliative care clinic to oncology clinic, and I'm a different person. That, again, I think we bring our skills. So maybe he's a better palliative care clinician because he knows oncology. Maybe he's a better oncologist because his palliative care skills, but you do wear different hats. And whether it can all be the same person, I don't know. I think my bias is no, but we will see. The second point, and then I can turn over to Jennifer, about insurance is we have never had a problem in the state of Massachusetts. Palliative care is approved care. We bill differently. I bill for non-small cell lung cancer and for chemotherapy, and they bill for pain and fatigue, but we've not had reimbursements, at least in the state of Massachusetts, ever in the 20 years that we've been doing this. But I don't know if it's different in different areas of the country.
I am not going to take up any of your airtime, but would love to hear from the practices who do have integrated palliative care, how that's worked for them.
Hi, it's Mike Stellini from Carmanos.
Hi, Mike. Yeah, we can. Thank you.
Yeah. So just to address what Jennifer said, I think that the model of integrative, we're lucky to work in a cancer center like Jennifer described, and have integrative care where we do the same thing of seeing patients on the same day. We get paid also because we bill for different things. There's only one facility fee for the hospital, but the professional fees are distinct and paid. The idea of being able to talk to your colleagues when you're seeing the patient is incredibly helpful. So I think it's an advantage that an integrated center has that maybe it would be harder, as Jerome was saying, when you're not in the same place at the same time. So I think, trying to figure that out for more community-based places is something we have to work on. But I think the integrative model where you can talk face-to-face with your colleagues, see them on the same day, is incredibly helpful to patients and families.
I just want to make the point that 40% of our practices are 1 to 2 physician practices. So we only have 3 large medical centers. I see Heather Kilpatrick, our guest, wants to make a comment on this. Thank you, Heather.
Sure. In kind of this discussion, first of all, I've been so inspired by what I've heard today. But one of the things with COVID happening throughout the course of this last year is we received many opportunities for visits with his oncology team, or again through Arbor Hospice, and we even met with his neurologist via remote visits. And we found it really wonderful, a wonderful way to communicate. It was logistically very difficult to get Liam into those visits. There were times where mobility was a very difficult thing. There was winter weather to contend with. There were other things. But perhaps, we're talking about logistics and getting more people involved in other things. It's much easier to be in one location and to see, and I'm not saying replacing an in-person visit, but we found it extremely beneficial. And from the palliative care side, they would change their backgrounds sometimes, and there would be a social worker and a nurse and or a physician on one visit call occasionally, not always, from different facilities. I'm not sure how they orchestrated it, some of which was done through Arbor Hospice. They had fun backgrounds. They knew Liam loved Mark Wahlberg, so his social worker Tara would have Mark Wahlberg in her background, just sitting there listening in, and so Liam began to look for backgrounds for his Zoom meetings, and it gave him a little bit of purpose. So I just wanted to, mention and really ask, I guess, if that's something that people are thinking about continuing long after, this COVID thing subsides, which hopefully it does. Anyway, just wanted to throw that in there.
I think that's such a great point, and I think we've all seen in the last few months lots of incredibly positive stories about telehealth video visits, but also lots of negative as well. Like there's been a lot of articles about disparities in care and all of the downsides. And I have to say, Heather, like you, I have really embraced the video visits. I think it is an amazing way to deliver palliative care. I'm obviously biased because we were doing our video visit palliative care study prior to the COVID pandemic. But I really do think it has a lot of power. I think being able to see patients in their home has been incredible. I think the ability to bring in family members from all over the country where they don't have to come in for a visit and they're not kind of ignored on a call really does enable better palliative care because you really are caring for the family. So I think it's clear from a reimbursement perspective that video visits will be here to stay. And again, where I think we will be tasked is how do we think about when do people need in-person visits? When do they need video visits? How do we schedule them? But I agree. Have really embraced it. I actually love doing video visits. As an oncologist, this isn't related to the palliative care research. I do one video day and one in-person day, and I love the video day. It's super fun. It does require new skills. You kind of have to be able to push yourself. You have to learn how to bond on video, smile on video. But I think once you get that down, it's really great, and patients and their families love it.
What do you do about those?
Experience. Some people hate it. So if you hate it, feel free to shout that out.
I did want to mention that we will be having a presentation in June on how to establish rapport in patient-clinician relationships in the virtual environment. So we have a grant application we're putting in, and the PI will be presenting what we know about the science about expressions and conveying warmth and empathy on a small screen.
Dr. Temel, we had another question back a bit to the cost justification of palliative care within these settings, and the data you presented on the benefit to the patient and caregiver and team in general related to communication and symptoms and overall health, I think are resonated with everyone I've seen within the chat, including those who have asked this question. Do you have ways or anecdotal evidence? It seemed what was presented up to this point didn't really relate necessarily to decreased healthcare utilization or costs. Do you have thoughts about where that may move in the future, or ways one who is looking to justify additional services could do so on that part of the equation?
Yeah, I think this gets complex.
Mm-hmm.
We don't want patients to perceive like we are holding care or trying to deliver care are just focused on cost. Nonetheless, from the data side, we have data that palliative care does lead to cost savings. Much of that work was done by Sean Morrison at the National Palliative Care Research Center in Mount Sinai and focused on inpatient palliative care consults, which I realize is different. But I'd say the inpatient palliative care data leading to cost savings is pretty solid. I think that data is convincing. Inpatient palliative care does lead to cost savings. In the outpatient setting, it's been a little complex because, you know, when you're talking about a patient who lives 3 years, calculating costs gets tricky. We did some work on this, and I would say we didn't do a great job because it was so hard, but we did have some inkling of cost savings as well. But again, I think the gray zone of, you know, we want patients to get the care that's best for them in line with their goals and wishes. And although I know sometimes we feel like it's a personal failure if patients get chemotherapy or get intensive medical care at the end of life, if that's what that patient and their family need and want, I don't think we should think of that as a bad outcome. So again, I think that holy grail of goal concordant care is probably what's most important. But I think we can confidently say palliative care, while there's added cost for them, there's enough data on the cost savings that I think moving forward with it from perspective value improves outcomes is the most important thing. And I think trying to move away from healthcare utilization being a good or bad and more thinking of it is what's best for patients and their families, even if that means dying in a hospital or dying in an ICU. But I know that, again, that's controversial. So,
well, perhaps, but your answer clearly puts the patient in the middle, and I don't think that's controversial, right? In the center of their care and choices. So that part seems consistent with what we should be doing.
Emily,
Thank you.
Can I say something quickly?
Of course.
So one of the things that I have been aware of, and we are looking at potentially, is trying to prompt CMS to create a model to see whether or not there is going to be some downstream cost savings by initiating and supporting, you know, a greater upfront investment in palliative care. I think that would be an important goal for CMS to try to do. I think that so the Center for Innovation may be looking at something like that, and we're going to, at least for me, one of those areas that I'm trying to explore to see if there's a way we can push that. So,
I mean, I think
can
the
I
other
ask,
CMS.
is Heather still on the phone, on the call?
I am, yes.
I just want to ask you a question. And I have to say, I listened to your talk and it was so heartfelt. And I have to say that I became tearful. And
Thank
I
you.
really do appreciate, and I can only imagine how you must have felt. Let me ask you, at some point, did you feel as if the oncologist that you were dealing with did not do the types of conversations that in fact the palliative care team did? Was there sort of a handing off of something that you would have wanted your oncologist to do that wasn't done?
I think that, you know, my son was treated in a very team-oriented place. He was treated, you know, in a pediatric setting. So a social worker would come in while we might be waiting for the oncologist to check in to see how we were doing. And then the oncologist would be there. So we received that care simultaneously on the same visit and had relationships with different people. It really, I mean, it worked for us. My son, though, spent the last 7 months in hospice care. So then we're talking about a little bit different because, you know, there was a team involved in his care that would come to our home or visit remotely for a time. So to me, it was just more people to love and care and express, you know, to help care for my son and our family's needs. So it wasn't anything that one doctor wasn't able to necessarily do, but we were grateful for that team that we had in place. So I don't know that I could speak to that because our situation was just very different. We were grateful to have, these various people that Liam had relationships with. Liam also became, he turned 18 and was then an adult through this process. And so there was some transferring of, ownership over his care to him. And that was could have been a tricky thing to navigate. And I was grateful for kind of that help in, he had to give permission for I had been there every step of the way, and now, the care was up to him, and gratefully because we had communicated, because I had been able to be there, it again was a pretty easy transition, but we were grateful for having a team. So I don't know how to speak to that exactly.
So you are to the best of your ability. Let me ask you, when Liam was transitioned into hospice, did the oncologist remain involved throughout that time with regular visits, whether telemedicine or in-person visits? That's a big issue that we see in the community, that once a patient is no longer under the care of the oncologist, that in fact they tend to, in many reputable institutions, sort of back away. And I wonder how your experience was.
We still found the weekly care transitioned to more of hospice, or the weekly or every other week type of check-in. With Liam, it was pretty regularly every week that someone was checking in. Our oncologist did keep in touch. We did have a remote visit towards the end of Liam's life. He passed in August, by the way, of this last year, so almost 6 months ago. And his neurologist certainly kept involved, as we were worried about his seizure management. So there were other people that we still consulted outside of that hospice team, although they were totally great at stepping in and fulfilling Liam's needs. We just had relationships that we had established throughout the course of the 3 years, where we still did have at least remote visits with a couple of his his doctors. Obviously, like the proton radiation doctors was for a limited time. But we did still have a visit or two with them.
Thank you.
Thank you, Heather. And I believe we're at time right now for this, and I just want to read Dr. Temmel's comment to you, because I think we all feel this way, Heather, about your involvement with this presentation, that we're just very thankful for you being here and sharing your story with us. So thank you. I
feel very blessed to all of you. So thank you.
Thank you, Heather.
Yeah, thank you so much. I do also want to comment that and remind everyone that's here that Dr. Temmel will be serving as one of the leads for one of our breakout sessions. And so I think that's important, because I know that there were still remaining questions or comments that members of our audience were hoping to discuss. And so you will have another opportunity.
Thank you, Emily, for moderating. And thank you, everybody. Thank you, Dr. Temmel. Thank you, Heather. And the breakout should be great. There are 2 other really great breakouts. They will be recorded. The only one that won't be recorded is the one between Dr. Temmel and Dr. Seid, because we want people to be able to be vulnerable, talk about mistakes. So we tend not to record those sessions. So we'll see everybody back here at 11, please. Please come back a little before 11 so we can start right then. We have Mike Harrison presenting our MOQC update, and Dr. Grant from Blue Cross Blue Shield will be joining us too. And Dr. Temmel, will see you back at noon, but please feel free to stay even if you have other things to do at the same time. That does not apply for the rest of you all. You have to be paying attention. Okay, we'll see you at 11. Thanks. Well, it's already 11 o'clock. Can you believe it? I stood up for the first time in 2.5 hours. That was fairly uncomfortable. So we're back from break. Could I have the next slide, please? Thank you. This is just to acknowledge your participation. I'm so incredibly gratified today. I feel like we really hit our stride in terms of participation, and we have 118 people still on the call. We just want to acknowledge the importance of our Patient and Caregiver Council, our hospices, for participating. They come to our regional meetings as well. We have incredible representation across the state. Hospices and palliative care experts coming to our regional meetings to help build community and communication. The Michigan Department of Health and Human Services is funding several of our grant projects now across the state through funding they have from the CDC. And also, of course, we couldn't be doing what we're doing without the sponsorship of Blue Cross Blue Shield of Michigan. And Daria Massimilla is our new manager through Blue Cross Blue Shield. Everybody knows Jackie Rao. Jackie is now working for the CQI office through the University of Michigan. So we want to welcome Daria. We will also be having Dr. Grant join us in just a minute to introduce himself and his new leadership role at Blue Cross Blue Shield. Could I have the next slide, please? Thank you. I'm really delighted to introduce two new people to the MOQC Coordinating Center team. This is how we have seen Nicole Timmerman, who's a senior project manager who joined our team, and Ermili Patka is a clinical data abstractor. You can see them today in much the same way you're seeing them right now on the slide. I've actually never met Ermili in person, but he's already become a valued member of our team. Nicole joined us one day for an in-person interview, but we've only seen each other on our screen. So please join me in welcoming Nicole and Ermili. All right, I'll have the next slide, please. I'd also like to introduce Linda Quinn Busterian. This is Sam, Sam's daughter. Sam, you haven't seen today on the call. She's out on maternity leave. Her daughter was born last week. She and Joe are in love, is a direct quote from them. We are madly in love. So you don't see Sam here today because she's home with Linda Way. I'll take the next slide, please. I also want to thank our abstractors. It goes without saying that we can't do what we do without data. These are the abstractors just for round 2 of 2020. So if I've missed you, I'm sorry. I even considered not including this slide because the risk of missing somebody is so great. And I just apologize if I have, but our data abstraction is a tremendous amount of work. You can see all the people who contribute to collecting data and ensuring that we have high quality work. Our MOQC by proxy members are listed in the bottom row and are really important. You'll see that Nicole, Louise, Cindy Mihalik's on here twice. Sorry, Cindy. Colleen, Ermili, Cleo, and Tiffany are all the folks who work with the MOQC Coordinating Center. If anybody, thank you, Emily, for thanking all the abstractors. Next, we're going to talk about the state of our consortium, and I'm pleased to introduce Mike Harrison's going to present the Patient and Caregiver Oncology Quality Council update. I'll turn it over to you, Mike.
Thank you. I've said this in many different venues and very often of all the volunteer work I do, the most rewarding is what we do with MOQC. And the biggest reason is because we hear it all the time and we certainly feel it all the time, the importance of the patient and caregiver voice. It's very clear that that's important to MOQC, and that makes our work and our effort feel very worthwhile. So having said that, and stop me if you've heard this before, we continue to look for new members. We have 9 members on MOQC now. That's a little bit lower than what we've had in the past. And it represents 4 of our 6 regions. The 2 regions we still don't have representation is Lake Superior East and CMG. So if you have practices in those areas, we'd love to hear candidates for that. If you have any candidates, you can let Vanessa Aaron know. We'd love to talk to them and convince them that MOQC is going to be worth their time. We continue to look for different diversity in MOQC as well, particularly different kinds of cancer. So that's important to us as well. And one thing we haven't talked about as it relates to POCSI, we know that meetings like this, regional meetings, we're always asked to provide that patient voice, and it's important. But one area that we haven't been tapped in and we're happy to do, I mean, we're kind of a built-in focus group for anything that you might be doing in your practice, in your hospital. If you need a patient perspective and a bigger picture than just one-on-one, if you need a focus group formed to get feedback, we'd be happy to do that. We haven't been asked to do it, but that's certainly a role we can play as well. So if that's something that you think is valued to you, we're ready to go with that. So there are 2 handouts, one for your practice and one.
Excuse me, Mike.
Yep.
Mike, can you
Yep.
just speak up a little bit, because
Yes.
some of our attendees aren't getting everything that you're saying, and it's
Okay.
important that everybody hears. Thank you.
I will, thank you. We are also, there are 2 handouts available for you, one for your practice and one that you can give to a prospective patient or caregiver who might want to be a member. So those will be, I believe, sent out after the meeting. So you will have those on hand too, to give you a little bit more information about POCSI and information for prospective patients or caregivers as well. So I do want to update you very quickly on a couple efforts that POCSI is involved in: financial toxicity and anti-racism. Those are 2 pretty important topics that were brought up independently by POCSI members. Financial toxicity, that interest was fueled by a breakout session at a previous biannual meeting. I think it was a year ago right now. And it was furthered by interaction with 2 U of M School of Public Health faculty who surveyed members, both POCSI and MOQC, for a research project they're doing called Addressing Financial Hardship to Improve Cancer Outcomes. So we are very much involved with that, and I'll come back to that in a moment. Anti-racism was identified by a POCSI member who wanted to learn more about anti-racism overall, and particularly how it relates to providing or improving cancer care. And all of that was augmented by a great presentation by Dr. Griggs at our last POCSI meeting, when we learned a little bit more about some of the efforts, some of the information that's out there. So at our next POCSI meeting, which follows this meeting this afternoon, we will identify a POCSI member to lead each of those efforts: financial toxicity and anti-racism, and then create teams around each of those topics to continue our understanding of each topic. And from that, we hope to create a foundation for developing an action plan for each topic that hopefully will benefit MOQC as a whole. Again, we've been involved with both, but now we're going to put a little bit more teeth into our work, I think, and create something that we hope will be of value to MOQC as well. So that's it for the update. Again, if you have any candidates for POCSI members, we'd love to hear from you. Thank you.
Thank you so much, Mike. I just want to add that new as of this year, we are going to be able to pay our POCSI members for their expertise. So very important group. It can help recruit people if they know that their expertise is so valued that we will pay them. I'd like to introduce now Dawn Severson, the chair of our steering committee. Dawn, are you ready?
Yep, absolutely. Good morning,
Great.
everyone. So I'm going to start with first, just as Mike said, please consider nominating yourself or a colleague for our next term coming up. It's really important that we have your participation. We value it desperately. And so if there's someone in the audience who would like to participate with the steering committee or are interested in some of our committees and task forces, which I'm going to describe in just a quick minute, we would be grateful to have you. So as you've heard through our previous conversations, the COPI database is actually going away. And this is actually really an opportunity for us to identify measures that matter to us and measures that truly can affect change of care for the better for our patients here in the state of Michigan. So we're looking for volunteers that are interested in being a part of this change. Most importantly, and coming up very quickly, is our MOQC database task force. This actually will be meeting coming up on January 21st at 6 p.m. So if you're interested in being a part of that database task force, not just clinicians, But also, even if there is people who are interested in measures, choosing measures and data management, that's a task force that we would love to have participation with. Again, as we're looking for this, for members for this database, it just so we're aware of what the time commitment might look like, it's probably going to be about 3 meetings, and those meetings will happen starting on January 21st and then fairly rapidly thereafter. So if this is something that you're interested in, please let us know. The other committee that is an ongoing committee and meeting in May on the 19th at 6 o'clock as our next meeting is the Measures Committee. So if you're interested in being part of helping with those measures, choosing those measures, please know that that's another committee that we are looking for participation for. And then thirdly, our Data Evaluation, Research and Publications Committee, that is an ongoing committee that we're looking for membership for. So if these are things that interest you, if you have colleagues that you know are interested in choosing measures and being part of looking at the data that we look at, we would love to hear from you. So if you're interested, please send an email to the MOQC or Jennifer or even myself. We'd be happy to hear from you. And I think that Louise just updated that in the chat conversation. So next slide. So just to update the membership as well, our keynote speaker for our June biannual meeting is Dr. Supriya Mohil from the University of Rochester. And we'll be very happy to have Dr. Mohil speaking at our next biannual meeting. Additionally, one of the things we wanted to update everyone on is that there are opportunities to further expand our measures and also further expand our value-based reimbursement in MOQC. So as part of the steering committee, we were brainstorming a few ideas that we had with regard to ways in which we could do this. So some of the thoughts that we had on ways that we could potentially impact would be looking at perhaps gold carding. And by what we mean by that is when we work with the insurance companies and those companies that are like Evancor that decide whether or not we can go forward with choosing things like PET or MRI for our patients, if we're following guidelines, if we demonstrate that we are an institution that follows that well, perhaps we can be chosen as a favorable institution and, if you will, gold card so that we don't have to go through so much of that burden on the practice for prior authorization. Another potential VBR that we had discussed about was looking at the adoption of biosimilars. Not a particular biosimilar, but as more and more biosimilars become available, really looking at what percentage we're using and the value that adds to practice and management of patients. In addition, another consideration that we had talked about was how we use tumor genomics and pharmacogenomics. How are we obtaining the test at a proper time frame for our patients on their tumors, and how we're using that information for choosing the appropriate therapies for our patients. So these are VBR measures that we thought would be reasonable measures as we go forward. This is from ideas from the brainstorming from the steering committee, but of course we're looking for ideas from our membership at large too. So if you think of an idea that could be a good VBR for us to look at going forward, we would absolutely love to hear from you. So I think that's about it for the update.
Thank you so much. I just want to ask you, Dawn, my sense is that the steering committee is really hitting its stride, and that the energy and ideas, it just feels like we've established a really great community.
Yeah, and I agree. I mean, it's been a great dialogue. Really, this most recent meeting before this meeting, some great ideas that we could see coming forward and bubbling up, and really looking at the changes that are happening with COPI as a true opportunity for us to start making decisions on measures that we think are valuable to us and valuable to our patients. So this is, I think, it's a great time, and it's a great conversation, and it's a great community that we have to be able to do this in. And so really, if there's anybody else out there that wants to be a part of that change, this is an opportunity to add something more, to really be a part of it. So I love being a part of it. I love being a part of such a passionate group of folks that really want to make a difference in the care of cancer patients here in Michigan. And I am absolutely grateful to MOQC for being able to be a part of that. And I know I'm not alone.
Dawn, thank you for your leadership. You've really been a tremendous part of MOQC's leadership. If folks want to thank Dawn and the rest of the steering committee in the chat, that would be very meaningful. It's not a lot of work, but it's such important work. Well, I'm very pleased now to introduce Dr. Grant from Blue Cross Blue Shield. Dr. Grant, I understand that you've joined the meeting. Thank you for being here. Okay. Daria, can you just nod if you...
I'm unmuted now?
Yes, you are. Welcome.
Okay, that's not bad. That's my first, Dr. Grant, you're on mute announcements of the day.
And I didn't even say it.
I pretty much, I think that's the most common thing that's affected my life. Oh, that's me. But my name's James, it's not Richard.
Okay, I don't know how that happened. Terribly sorry.
That's okay. It's no big deal. And I'm not the president of Blue Cross. I think that would get me in real trouble with my CEO.
Yeah, we won't tell them. We just promoted you.
Okay. Yeah, no, I wouldn't tell them. Otherwise, I may get the ultimate demotion.
Uh-oh.
But thank you. I think you can see from the slide that's up. I haven't gone through the rest of the details yet, but my name is Jim Grant, not Richard. I'm the new CMO of Blue Cross Blue Shield of Michigan, and I'm just thank you for inviting me and for allowing me to participate with your CQI. I'm a strong supporter of the CQIs in Michigan, and I think there's just the value that they bring to patient care and patient safety it's almost unmeasurable. And I continue to support their advancement and their growth. And I just want everyone here to know that you have the total support of me and the organization moving forward to continue to do the great work that everybody's doing. A little bit about my background is I'm pretty much spent most of my life in Michigan. Did medical school at Wayne State, went to Northwestern in Chicago for residency, came back. I was at Beaumont and Royal Oak for 28 years. I'm an anesthesiologist by background. 13 of them as the chair. Went off a couple of years ago to Cedars-Sinai in Los Angeles to lead their perioperative service line. And came back for this really unusual opportunity. In Michigan, and I've learned it elsewhere. I've learned it elsewhere once I left. We take Blue Cross Blue Shield for granted, but Blue Cross Blue Shield, we're more than a payer. We want to be a partner. And I've always been a physician advocate. I've always been a physician first. I will continue to be a physician. As a matter of fact, somebody during this group texted me, do you miss being in the operating room? To be very honest with you, I do miss being in the operating room. At the end of the day, that's what's in my DNA, is to be a physician. I'm working on getting back into the operating room a day or two a month, so that I continue to be clinically active, so I can understand what the issues are. And so if I understand what the issues are, I can do better to help you do the great work that you're doing. Never hesitate to reach out to me. I'm available pretty much. I'm pretty accessible 24/7, and look forward, really look forward to the day that I get to meet everybody in real time.
Thank you so much for being here. We're correcting the slide as we speak. Our apologies for that.
Hopefully that's the worst thing that happens all year.
Well, I hope so. And we're really grateful for your leadership and the support from Blue Cross Blue Shield. And I don't just mean financial support, but really vision. So thank you. And we will fix this before we send it out.
It's already fixed.
Yep, that's Vanessa for you.
Okay.
Thank you, Vanessa. All right, well, thanks very much. We're going to move now into our how are we doing as a collaborative? I'll have the next slide, please. I'm going to go through the next 11 measures. I just wanted to give you sort of a heads up about what you'll be seeing. Tobacco cessation, counseling provided or referral made, How are we using antiemetics in patients receiving chemotherapy? How are we doing monitoring and coming up with a plan of care for pain? Hospice enrollment, the timing of hospice enrollment, whether or not we discuss it, even if the patient doesn't go on hospice, chemotherapy in the last 2 weeks of life, and I'll be showing you data on advanced imaging order in the staging setting for early stage breast cancer. We have 2 rounds of data for 2 measures, growth factor use in the non-curative setting with the first cycle of chemotherapy only, and actually with the first dose, and then also a complete family history, whether it's documented or not, in people who have invasive cancer. I'll have the next slide, please. Thanks. We're going to show you in the figures 2 periods of data. The first is data you've seen for your region and practice, but not for the whole collaborative, for the last round compared to the last year. And your data from the round that just closed in early December will be available to you in February of this year, and of course at our regional meetings. Next slide, please. So just in case you haven't seen the new way we present the data, the first histogram, the first slide, will show you the most recent round of data by practice. And then the second histogram, which will be animated, and it'll change until I ask Vanessa to advance the slide, it'll go back and forth. The practice will stay the same. So where your practice is on the first slide is going to stay the same. And then there's a little caret to show if your performance has gone up or down significantly. So this doesn't just mean the estimate, it means is it statistically significantly different. I'll take my time on the first slide so you can get the hang of it. Next slide, please, Vanessa. So this shows you tobacco cessation. 332 patients were eligible for this measure. And this is what it was over the past year. And then what you'll see next is the current round of data. MOQC is in the dark purple, COPI, which is the national data, is in green. And you can see even though things improved, it wasn't statistically significantly different, although practice 20 had a statistically significant improvement to 89% from 56%. My kids would say, woo-hoo. So that's what all the slides will look like. We've done very well as a collaborative. The target was 75%. I'll have the next slide, please. I'm not watching the chat, so unmute yourself if you want me to slow down. This slide shows you whether or not we're using appropriate 4-drug antiemetics. It's a 4-drug regimen that includes both an NK1 receptor antagonist and olanzapine. You can see practice 20 is at over 70%. Practice 120 is at 52%, up from 31% now, but that's not statistically significantly different. MOQC as a whole actually went down. So our practice is this, we have a lot of room to go to improve, and practice 27 is the only one that improves statistically. This is in 588 patients. The next slide will show you the opposite, which is, next slide, please, Vanessa. This will show you overuse predominantly of the NK1 receptor antagonists, which are very expensive and don't add value in terms of quality of life. Our target is to get this down to 30%. We've made a lot of improvement. MOQC as a whole is down at 15%, and we were at 19%. We've just been coming down each cycle. This has really been due to the leadership of Emily Mackler, and before her, Emily and Kelly Percalo worked together on this. So we're doing quite well. Modifying your order sets has been probably the most important step in decreasing overuse of the NK1 RAs. Vanessa, the next slide, please. You're doing a great job on this. All right, this measure looks at whether or not pain was assessed, quantified, and a plan of care documented for moderate to severe pain. We are doing very well on this measure. No statistically significantly changes except in MOQC actually as a whole. So in the 525 patients, we went from 93 to 90%, but this measure is essentially topped out. Practice 101, anything we can do to support you to improve performance on this measure, but this is a document measure, right? We really want to see patients feeling better. So this is better as a patient-reported outcome measure. We have some updates on that if we have time today. Vanessa, the next slide, please. I'm just going to have a sip of water. Hospice enrollment has been a focus for the last couple of years. Our target is to have 50% of patients dying of cancer die with hospice support. COPI as a whole is at 63%. We've always lagged as a state behind COPI, but we're catching up now. And we have had across the consortium a statistically and clinically significant improvement from 50 to 57%. And you'll see that one of our practices, practice 25, also improved significantly. At our regional meetings, our exemplar practices shared how they've done to improve performance, the things that they've done. Thank you, Amanda. Amanda says, that's awesome. Yes, this has been incredible, and I want to shout out our hospice partners and patient and caregiver council for helping us with this. The next slide, please, Vanessa, shows how long people are on hospice. So this is a measure where we want people on hospice to be on for more than 7 days. And you can see that we now have about 40% across the collaborative of patients are on for only 7 days or less. And we want to see people benefiting from multidisciplinary patient-centered care for longer. So it's not statistically significantly different. It's just the play of chance. Practices 80 and 104 have improved. This isn't that their number of patients on for this short amount of time is better, is larger. It means that they've improved significantly. So well done. All right, the next slide, Vanessa. You're doing a terrific job. These animated slides can be really tricky. And then one of the things we wanted was to help our clinicians and social workers, our multidisciplinary teams, get more comfortable having these discussions, even if patients didn't go on hospice. And you can see we've really done a terrific job at not just having the conversations, but documenting them. This measure has been removed from the COPI database, and it's also not a measure that we want to really rely on. We want to see actual enrollment on hospice, but I would just like to just commend us as a collaborative and all of you for everything you've done. And remember, we have resources on our website that are MOQC, they're practice agnostic, that you can share and use with your patients and the rest of your practice partners. Next slide, please, Vanessa. We're doing really well here. We're almost done, and then we'll turn to discussion. Chemotherapy in the last 2 weeks of life, lower is better. MOQC as a whole, and really all of our practices for the most part are quite low on this. We do have some practices that have improved. Practice 101 has improved, and overall we're doing quite well. I'll have the next slide, please. This slide looks at overuse of advanced imaging in people who have stages 1 or 2 breast cancer. As part of the care of these folks, we generally don't recommend advanced imaging. If patients are on a clinical trial and need advanced imaging, that they're excluded from this measure, and patients with symptoms are also excluded from this measure. So we're overall doing quite well on the measure, with some practices still ordering advanced imaging. Anything we can do to help prepare materials for patients or those people in your practices that you would like some help with, let us know. That's what we're here for. I'll have the next slide, please. And then I'm going to show you those 2 measures for which we only have 2 rounds of data. So it's 1 round compared to another. We're still collecting data, obviously, and then we'll be able to show year-by-year comparisons. So the next slide, please, shows you growth factor used in patients getting chemotherapy with non-curative intent. And this is with the first cycle. You can see that COPI as a whole, so nationally it's 7%, MOQC as a whole was 7%, and I believe this is all due to COVID, right? Doesn't everybody agree? If you want to show me the thumbs up reaction, that we know one risk factor for people having worse outcomes with COVID is being neutropenic. And so this is expected. This is, I think, clinically appropriate care. If somebody wants to argue with me, I'd love to hear it, but this was expected and predicted to keep our patients safe during the COVID era. Next slide shows family history. So a complete family history is first and second degree family members, whether or not they had cancer, and if they did, at what age. We're neck and neck. MOQC is neck and neck with COPE, and some practices are already showing improvement. Our NIH NCI funded grant is hoping to give you tools to improve the quality of the family history completed by patients. So you shouldn't have to spend more time with the patients. The quality of the information will be better and will be more complete. So that's in 1,934 patients. A lot of patients contribute to this measure. And if you haven't heard about the MITE study, you will be. So I'll have the next slide, please. In summary, and we'll go to discussion in just a moment, but in summary, we are doing really well. To me, this shows the power of our collaboration, working together, bringing attention to, explaining why a measure is important, and then acting upon it. The performance has been excellent for the 4 value-based reimbursement measures, really across the collaborative. The attention that you've all paid, the resources. I want to shout out to our administrators and our nurse practitioners, our nurses, and our social workers. This just highlights the value of multidisciplinary care. Our VBR year begins March 1st. You'll be getting paid out for your past performance. The place was, if you don't get the VBR, it's because coming to meetings hasn't been something where you've shined. We always give a practice a buy if there's something like a move of your practice or a change in EMR, or all your doctors are leaving and you're bringing in new teams. Just reach out to us. Our measures committee meets in May, like Dawn presented already. And really, this is our chance where we create new measures, which we've been able to do before as MOQC. We created a whole bunch of measures, but this is the time where we can really decide what do we want to focus on for the next couple of years in MOQC. So even if you haven't come to a measures meeting before, you're part of the measures committee. We'd love to have you come. You can come for one meeting and see if you want to stay part of it. I'll have the next slide, please. These are our measures going forward for 2021. If a couple of these look different, it's because COPE communicated with us that a few things aren't being collected in COPE. And though this is our last year with COPE, we do use the COPE platform. They can't support measures that aren't in the COPE measure set. So you'll see that the NK1 receptors are in here, oral chemotherapies in here. We've always collected chemotherapy intent, curative versus non, but it's not been one of the measures we've shown you, so we have baseline data. So keep focusing on that. The complete family history, of course, growth factor administration, hospice enrollment continues to be a VBR measure, as does time on hospice. Chemotherapy in the last 2 weeks of life will stay there as well. And the percentage of patients who die from cancer with one or more emergency department visit in the last 30 days of life has been added as a measure. The measures committee was a little mixed about this, but we lost a couple measures from the measure set that was approved. And this was already in our COPE measure set for MOQC, so we decided to keep it in. We'll see how it goes. There's no VBR attached to this. Okay, great. I'll have the next slide, please. Our quality projects continue to be tobacco cessation. This is funded through a grant from the health department. Oral oncolytics, a big focus of Dr. Mackler's work. Hospice enrollment, of course. Chemotherapy-induced nausea and vomiting, how we manage that. As Dawn mentioned, we're looking at gold carding opportunities. We're partnering with primary care pharmacists to provide support for complex patients, those with multiple comorbid conditions. This would be a transplant patient. And we're also piloting fatigue management. In addition to the tobacco grant, we also have the MITE grant. We're looking at family history and appropriate referrals. We're standing up our advisory board, which is really excellent representation from patients and families. Cancer Thriving and Surviving is a survivorship grant. Reach out to us if you want to learn more about this. It's a self-management program for people who've had cancer. And then we have an ovarian cancer grant from the health department and have podcasts for patients with interviews with our own GYN oncologists and MOQC and other resources as well, including ways to help support GYN, OBGYNs who are not GYN oncologists and patients find a doctor who specializes in GYN oncology. I know I've covered a lot. I'll take the next slide, please. So our strategic objectives, MOQC just went through strategic planning, and thank you to those on our patient and caregiver council and to those in our practices who participated. In addition to focusing on the professional development of our own team, I want to make sure everybody knows that we're going to be centering equity. All of our clinical initiatives will have a focus on looking at our underserved patients. We're maximizing value. What that means is we want to increase the value of MOQC to you. So if you don't like something we're doing in MOQC, we can't fix it if you don't tell us. We'll be reaching out to you to find out what could we be doing more of? What would you like us to do less of? What should we do differently? And we also want to make sure that we increase care to patients. So we're not just talking about, when we hear value, a lot of times we think about saving money. It really has nothing to do with saving money. What it has to do with is, are we adding value with our healthcare dollars? And this is a focus regardless of insurance type or payer that our patients have. We want to be good stewards of our healthcare dollars. And our third strategic objective is in line with our new data engine, which is generating trusted data. Thanks to you who've given us feedback on what we can do to increase the trust you have in those slides I just presented. We're going to be increasing the number of charts we abstract. Right now, we abstract data from 4,000 charts per year, and that's due to that, all those abstractors I showed you and called out earlier. I want to increase that to 20 charts per clinician, per measure, per round. This is how we get trusted data, where we actually see if those changes that we just showed you in our animated slides, are they significant or are they just the play of chance? We can't do that with 80 patients or 200 patients in the whole state of Michigan. So this is really part of our strategy going forward. And I want to thank Blue Cross Blue Shield for getting behind our strategy and supporting that. So you'll be seeing a lot of changes in the MOQC team as we enhance our own workforce. I'll have the next slide, please. So I'd like to open it up for discussion in the chat, which I can actually look at now that I'm not showing slides. And you can ask questions, but even better, unmute yourselves and ask some questions.
Okay, Jennifer, it's Jerome.
Thank you.
Why does it take so long for the length in hospice measure to be increased?
Oh, that's such a good question.
I mean, we seem not to move the target fast enough.
Oh,
for me anyway, personally.
Yeah.
What's the issue?
Okay, so just so you know, we were at 3 days or less. That was our target before. And you and I have agreed it really should be 30 days, right? So I think by scooching it to 7, I feel like we're making a clear message. And I know that a lot of people on the call have opinions about how good are we at prognosticating. So thanks for bringing this up. And I'd love to have other people if you're from a practice where this is going better, share what you're doing. And, especially in light of our conversation earlier, what can we do to help? I'm going to start calling on people, so you might as well unmute.
While people are thinking, let me ask you another question, because I saw something, and I'll be getting back with Dr. Temmel when we do the breakout. But what I saw in one of her slides showed, 80% or more of AML patients ended up with a hospitalization near the end of their life. And whether they had palliative care or not. Both were 80% or so. The question I have is, are we as an organization now looking at hematology patients as a separate group, because their needs and their experiences are different? And I will say that I have been looking at issues of transfusion within the hospice benefit, because these are sometimes obstacles that hematologic patients, whether acute leukemias or myelomas or myelodysplasias or myeloproliferative neoplasms, get into. And it's a barrier for hematologists or people who do a lot of hematology, let's say. And it makes me wonder, are we devoting enough time in that area? And could we devote more?
No and yes, we're not, and we are going to. I wonder, I see Hope on my screen. Hope, what are your thoughts about transfusion and patients on the hospice benefit?
You know, I think it can be a difficult matter to deal. I don't know that there's one answer. I think every hospice considers what is open access. That's how we refer to transfusions or ongoing you know, hematological concerns a lot of times. So it is often, we take it on a case-by-case basis, and we look at the person's condition and the person's, I guess, level of function and what that exactly is doing for them and what it means to them. But I do think for us bigger kids of hospice, the larger companies, it's easier for us to have those open access abilities than the smaller ones, because there isn't an extra reimbursement for that. That's you know, we get what we get, and whether it's someone who's not doing anything open access or whether it's someone who is getting those transfusions. So I would say that our medical director would probably say that that's a, you know, that's a tricky line to walk, but we want to take it, you know, I guess we want we want the ability to help a family walk through that, what that looks like, and also have our clinicians, have you guys talk to families about whether this is something that's uniformly helpful, whether this is help them see if this is a picture that changes over time, whether there's kind of decreased, you know, what the economies of scale are on this, you know, will they get as much bang for their buck at one point in their disease trajectory as they do in another part? So I don't know if that's an answer even.
That's helpful. And I'm thinking, oh, sorry, go ahead, please. I'm not going to talk.
No, I'm sorry. It's Mike Stellini. You know, I think as Hope was alluding to, this is clearly a cost. It's not in the current hospice payment mechanism to include something like a transfusion. You know, the unit of packed red cells costs $500 itself, not counting administration, nursing time, et cetera, et cetera. Anecdotally, when I was working at the VA, I had some folks who were over 65, so they had Medicare and they had VA benefits. And so I took advantage of left hand and right hand of the government, not communicating, I guess. I don't think it was illegal, but I had some folks advantage of hospice through Medicare, and they came to the VA and got transfusions for a few more weeks. And so they got the advantage of hospice a bit earlier, which I think was very helpful. But they, as long as they thought, or we thought, they were benefiting from transfusions, you know, they got them. And usually by the time we got them in, you know, we were explaining that at some point when you get a transfusion and you don't feel better, that means it's not just anemia making you feel bad, and that's when they end. But I think in those few cases that I had, they got hospice benefit much earlier, which I think was very helpful. It's all about money, and you can't blame anybody for it, except that's the payment mechanism. We're doing 21st century medicine with 1983 rules.
I just support what Mike says. This is John Mulder out of Grand Rapids, and the key is what's the benefit symptomatically to the patient. Really, that with the hospices I work with, that's the sole determinant. Do they have improved quality of life? One of the difficult things that we have on the hospice side is convincing people that we're not going to do CBCs. We're not treating numbers, we're treating people. So when we make decisions for transfusion, it always relates to what was a symptomatic benefit that you've received from transfusions and how long has that benefit lasted. You tell us when you're having the symptoms that suggest that transfusions are going to be warranted. I've had people do just fine with hemoglobins of 5. I've had people who are profoundly symptomatic with a hemoglobin of 8. So we don't do by the numbers, we do it by the symptoms. And as Mike also alluded, we also then would take a look at the extended benefit. And if they're no longer, we let them know that there's going to be a time in which they are not going to receive benefit. They're not going to be symptomatically improved as a result. Or if they're only getting 2 or 3 days benefit out of a transfusion, it's no longer of value.
Don, do you think that an early intervention with palliative care in that setting would be helpful in moving that discussion
Absolutely.
in the direction that we need?
Oh, absolutely.
Because ultimately transfusions are symptom driven typically for us as clinicians, and yet there's a misunderstanding that does exist, and patients view these transfusions as improving, and taking them away is sometimes seen as life ending, and yet it's not. And these are clinical decisions. I mean, so would you use palliative care and those things to help you along the line?
Absolutely. I mean, this again, one of the cores of palliative care is engaging in the conversation of what the values are for the patient, what the expectations are for treatment outcomes, whether we're talking about tumor-directed therapy or palliative therapies. Our goal is to find out what's important to the patient and allow them to live as fully and abundantly as possible. If a transfusion helps them in that, then great. If it doesn't, then they shouldn't receive it. But yeah, I'm pretty militant about that. So there's probably going to be not too many places where you would say, would palliative conversation be a value that I would say no.
Maybe it'll be helpful in my life so I could have a more abundant life. I just want to make sure everybody knows about our palliative radiation therapy pathways. You can go on our website and find out more about this. We are partnering between hospices across the state and radiation oncologists. We're getting in the middle to increase enrollment to hospice by making radiation therapy available. Hospices have agreed, radiation oncologists have agreed to a level 3 visit, same-day simulation and treatment unless the patient wishes otherwise. And this is transformative. And as I'm listening about transfusions, it feels like we have to transform healthcare. We can't keep doing it the same way. And when we think about our patients with hematologic conditions, this feels like such an important area. Perhaps we could have another pathway for how we think about transfusions and patient care. I don't know, Jerome, if you want to help me head that up with the rest of our amazing MOQC members.
I don't know what to say to that other than I have been working on that within my office to see whether or not we can propose something again with CMS and CMMI to see if we can create a model that might allow us to demonstrate the value of a potential transfusion carve out so that hospices are not burdened with that expense. And we'll see ultimately that as patients decline, that the use of transfusions will decline as well because the patients will not be able to travel and so forth. So I have something that's, I guess I'm interested in and I've been pushing a bit. So it takes time, but we know that there's data. I've read things and we might want to look at Tom LeBlanc's data out there on this. There's quite a bit. Let me also say, you talked about the funding issue and so forth. There's a Jerry Powell podcast with Sean Morrison, Dr. Morrison from Mount Sinai, and he addresses issues of palliative care and funding and so forth, and the need to reform our healthcare system, which is really, unfortunately, based on a population that no longer exists. We used to have a different type of view of a patient's lifespan and how things went. You had a disease and you died at a certain point. Now we have people living with chronic illnesses much, much longer. And our system of payments is really based on data that's from the 50s and the 60s and the 70s. And so it doesn't fit. And it really does need a ground up reform. That's a tall order. So, but I think we're getting at the conversation, which is good. how and who does it and how we do it is a billion-dollar question.
Thank you. I'd love to call on Dr. Sherry Lewandowski to hear your thoughts. You're unmuted, but I can't hear you.
I agree that I can think of several patients in my practice that can benefit from transfusions. They also sort of hospice. So I do agree that there is sort of a disconnect between what we should be doing and what's allowable or what's the easiest path for our patients.
Thank you. How about you, Dr. Timothy Cox? You're still on. What are your thoughts in listening to the conversation? See, I told you got to stay awake.
It's, I don't know, wow. Where do we really start? I mean, it's interesting, Jerome's comments about us using data from that's not relevant anymore, but there's certainly a lot of room for improvement. It's just, wow.
Well, that sounds like an endorsement. Dr. Caffrey, did you want to comment?
Actually, I agree with developing maybe a pathway. My issue, I deal with a lot of GI malignancies, and some of these patients transitioning to hospice, not necessarily actively dying, but maybe they still have 3+ months of survival, go on TPN. So do we really have guidance, and can the hospice handle a budget of a TPN? It's not a major issue, but it's stuff like that, like IV pain medications when they are in hospice, TPN, blood draws if we put them on TPN, and so on. Is there like a little pathway that we all can benefit from? Obviously, we try to avoid doing futile things, but sometimes just selling the patient and the family the hospice deal is strong enough not to allow DNR, not to allow us to withhold TPN and everything else. So many issues I think we still need to work on.
There are. Thank you so much for bringing up the issue of TPN.
Email address is mark.sierra.
Is there anybody else who would like to comment on any of the measures or any of the opportunities we have in MOQC to support you and your patients? I see Patrick Miller's on. I don't know, Patrick from Hospice of Michigan, if you want to comment about how you help patients transition from TPN off TPN, or what's your approach? I'm sure it depends on the disease process.
It does. And, even back to the transfusion discussion, a lot of this is physician to physician conversation. I appreciate what Hope said. Size of an organization can play a role with the expense that can be involved. But unless you have a solid physician to physician discussion, you bring the patient and family and have a real honest dialogue, and then evaluate how can we come to a common ground. Maybe there's a period of time where more expense is absorbed as you work towards weaning from TPN, as you work to no more transfusions or whatever it would be. It's got to be a conversation. It's not a one-sided, it's not a unilateral. So I hope that's helpful.
It's so interesting to me. We started out talking about conversations and communication, and here we are full circle.
Absolutely.
Yes, thank you. Hope has a comment again. Thank you, Hope.
Yeah, one thing that comes to mind that hasn't yet been mentioned is in hoping, and with physicians hoping that some of these higher level interventions can happen in a home setting, and knowing that, as I like to tell people when I meet with them, we visit and we leave. People aren't getting a 24-hour caregiver to be in their house. How is this being managed in a home, for a patient or a family? Are we having to teach families to undertake some of these interventions themselves? Or are we, expecting that some of these things might require someone going somewhere to have a treatment. And it's certainly gotten more problematic with COVID, I think, but it's always hard. You know, my mom at the end of her life, she had died related to metastatic cancer, but we were barely able to get her in and out of a car. And that was dangerous for her, but, you know, and difficult and distressing for us too. So just bearing in mind that while we can do something, should we do something, and can we safely do it, I think is a huge part of what needs to be taken into consideration. So that's just my kind of, from different sides of the bedside, observation on some of these more advanced and aggressive therapies. So thanks.
Thank you. I want to thank again all of our hospices, the experts from our hospices for being here, not just at the biannual meetings, but also at our regional meetings. I see that Dr. Tummel, you've come back on. I don't know how much of that you heard. We were talking about transfusions in the hospice setting for people with, you know, moved by your data on the hematologic malignancies. All right, we have just a couple minutes before we go to the break. If Vanessa, you could stop screen sharing. So we have a change.
Jennifer?
Yes,
Lisa Galloway would like to provide a comment. Sorry about that.
That's okay, Dr. Lisa Galloway, please go ahead.
Hi, sorry. I just know that sometimes I have the hospice discussion, and when I say we're going to stop transfusions, it's kind of like the deal breaker and they won't go with hospice. But if they thought they could come in to the infusion center and get a transfusion, they'd go with hospice. And then I think they'd recognize that they aren't feeling better and it's hard to come in, and that we'd have an easier transition. So I have so many patients that are done with treatment, but they're just not done with the transfusions. And it takes, you know, a couple times before they're ready.
It's often that way with chemotherapy too, isn't it?
Yeah.
Yes. Well, thank you for that. I think we've got the opportunity to think of some novel ways that we can harmonize care across the state, because the last thing we want is for care to vary depending on where you live, and we know it already does. So this is such a great, rich conversation. Thank you for that.
It's easier for patients to give up their chemo because they tend to give up side effects. So they'll view that as a much easier decision. So, you know, many people are relieved when chemotherapy is not held over their head. They might view it as, gee, if I don't do this, you know, my physician will be angry with me. I'll be disappointing my family. There's a lot of baggage that comes with that. Transfusions are on the opposite. We give them to make people feel better. It's rare that someone feels worse with a transfusion unless they have congestive failure or something like that. So it's perceived in a different way. It's more life affirming and therefore has a different context for people.
What a good word to end with, life affirming. If everybody could share their video for a moment, I have an announcement to make. Over the last 6 years, Louise Bedard has served as our program manager for the Michigan Oncology Quality Consortium. During these 6 years, MOQC's been transformed. We now have, very important, a patient and caregiver quality oncology council. We have a multidisciplinary steering committee and our measures committee. Our clinical initiatives don't include just 6 or 8 practices that want to participate, but rather every practice is participating in our clinical initiatives. We've more than doubled the number of patients included in our data. We've developed a regional structure where we come to you. None of these changes would have been possible without Louise's expertise, experience, creativity, leadership, and service. And I know you've all been recipients of her great care and compassion. She cares for all of you and all of us in the coordinating center in ways big and small. Louise is going to be leaving MOQC this month. She will be terribly, terribly missed by us on our team, and I know by all of you. If everybody could please take a moment and thank Louise for her leadership and her service, and put something in the chat or unmute yourself. Use your reactions like Cleo just did. Thank you, Louise, from the bottom of our hearts for everything.
I never thought of the day that would come that she would make this decision. We always try to really hang on to the big support that we get out of MOQC, and not just Jennifer's face, but Louise's face and Sam and so forth have become sort of the icons for MOQC, so to speak. And but we also know that we have to move forward, and I know that Louise will support that kind of perspective. And but we truly are going to miss you, Louise. I often called you Mother Louise, but although I'm older than you, I didn't feel comfortable saying that. But you are Mother Louise. What can I say? But happy retirement, if this is what it is for you. And I'm sure that your family support is just as strong as the MOQC support that you have given to us. Thank you.
Well, thank you, Ernie. I really appreciate that. I want to thank everybody that's on this here at the meeting today, and the people that are in your practice that are not on attending the meeting. Like most of my previous positions, I've learned much more from you than what I feel I've contributed. I want to thank you for your patience with me and your tolerance of some of my quirky behaviors and my Canadianisms. I really appreciate everything, the time and the effort that you've shared with me. I feel like MOQC is in great hands with all of you, and of course under Jennifer's great leadership. I need some time off to take care of myself, and I appreciate the fact that many of you as caregivers would understand that. So I know that with all of you continuing in your roles as MOQC and oncology leaders in the state, and under Jennifer's guidance, you're going to make much more strides in terms of care to cancer patients and their caregivers. And I look forward to hearing about those things and seeing you in publications and hearing all about that. So I'm not leaving Ann Arbor, and I'm remaining friends with many people that I've met through the consortium. So again, I just can't thank you enough. So I think that probably is the best that I can do right now, or I'll be a blithering idiot. And anybody that will come to my breakout won't, I'll have to find somebody else to run the breakout. So
I hope you can see the chat, Louise. There's so much love for your quirks, for your service. There's just so much in the chat, and this gets saved when we save the meeting. So you'll have a going away card signed by everybody. I've never seen such participation in the chat. I'm so moved by everybody.
Yes, see, that means that everybody does know how to use the chat.
Oh my goodness, you're
really
right.
Wonderful.
That's true. You all can't claim you don't know how to use it.
Yes, exactly.
You're so true, because I put a couple of things, but I couldn't move it to, go away.
Pat
I
Gager
can't
said
think
busted.
of a better person to speak up than you, Ernie. Anyway, thank you again. So I think if we can just go to some of the, I think, instructions for the breakout, I think that's a great transition. So as you all know, we have the last 50 minutes of our meeting coming up, and you have a choice of a breakout session that you can go to. You can, now nobody is being asked to attend one session. You can choose which one you go to. So the first one, of course, is continuing our conversation with Jennifer Temmel, and it's being facilitated by Jerome Seid, which should be very interesting. But we'll have a hard stop at 1 o'clock since Jerome does have another meeting at the end of that session. Dr. Emily Mackler will be presenting How to Poem, and that's around our pharmacist initiative that is being piloted right now in one practice and 2 physician organizations. And if you're interested in that program, that is the one to go to. And then there is the third session, which is really an overview of cancer care in times of COVID. You're welcome to attend any one, but you will be asked to choose one. To do so, there will be a screen that will be up, and you're asked to click on the button that you'll find yourself, and you get to share which room you wish to go to. And if you leave by mistake out of your breakout room, you just log back into our meeting. That takes you to the main room. Dave, our administrative specialist, will be there, and you'll be able to log back into a breakout room. We are not asking you at the end of your breakout session to come back into the main room. You will be able to leave from the breakout room, and each of the breakout sessions have the same closing comments by each of the facilitators. And Jerome, please do not worry about your breakout session. Either Shayna or Jennifer will review the closing comments. And so everybody will be able to leave from their breakout session and continue the remainder of your day. And we hope that you'll enjoy your weekend. And then the last piece is just to remind only the physicians that are here representing their practices. We really want you to fill out and complete your CMEs for this meeting, as that is the methodology we are using now to count participation for your commitment to the biannual meeting and counts towards your VBR participation. Now, of course, anybody else that needs to the CMEs, please go ahead and do so. And we will be sending out any follow-up that we promised during the chat. We will be sending out this deck and Dr. Temmel's deck. And as part of the end of this deck, you will have instructions to create your either CME account and or to remind you how to get into your CME account so you can get your hours. Okay, is there anything else? You can unmute yourself if you have any questions or put them in the chat. Otherwise, we will all go now to our breakout rooms and continue our discussions on those particular topics.